I'm just going to highlight some points today with Research Day. So, first of all, this is an exciting day for us all. We can hear each other's research and ask questions and just understand what we're all doing and thinking. But we couldn't do this today without the help of some key individuals that I do want to highlight again, and that's Sukaina Davdani, Nicole Smeck, Alyssa Malio, and Jillian Barroza, and of course our faculty who've worked with me, Peter, Chris Kellner, and of course our system chair, Dr. Betterson, who really have helped us kind of guide things. Isabel, who also provided some important feedback for Research Day today. So really great and looking forward to it. And of course, all the mentors that have spent time with our residents and our students should be represented and honored here as well, because it does take extra effort. So we're really happy that we've been able to do this with our students and residents. A couple other things, for the first time this year, we actually had 6 panel judges score the abstract. So the presentations that you're hearing today are the top 20 presentations that had the highest scores. So the presenters will have 5 minutes to present. There'll be 1 to 2 minutes per question, and we really would like the presenters to stick with that. Each of the sponsors/mentors will be present for the 1 to 2 minute question session. So I think we're ready to start. So we're going to start out with Jeffrey Zimmering, whose mentor was Dr. Margettis. The presentation of his title is Chronic Pain-Mediated Regulator of G Protein Signaling, Gene Expression in Superficial Dorsal Horn of Spinal Cord and Dorsal Root Ganglion in the Mouse. Take it away.
Thank you. I'd like to present a brief synopsis of some of the work I've done this year in Dr. Zachariah's lab, investigating a role for RGS4 gene expression in the mouse spinal cord and DRG in the maintenance of chronic pain. According to the IASP, the global prevalence of chronic neuropathic pain is between 6.9 and 10% of the general population. As shown in this slide, a high proportion of patients suffering from spinal cord injury or radiculopathy also suffer with chronic neuropathic pain. RGS4 belongs to a family of highly conserved proteins that modulate G protein coupled signaling by terminating the GTP active state of the heterotrimeric G protein. Prior work has demonstrated a key role for RGS4 in the maintenance of chronic pain states. Today, I'm going to present my data in support of a novel role for RGS4 gene expression in the superficial dorsal horn of the spinal cord and the DRG in the modulation of chronic pain signaling underlying the maintenance of chronic pain. As shown in this schematic diagram from Dewan and co-authors, C and A delta nociceptor afferents synapse in the superficial dorsal horn on excitatory somatostatin interneurons. These interneurons amplify mechanical pain signaling in projection neurons. On the other hand, dynorphin-expressing inhibitory interneurons mediate sensory gating of nociceptive signaling by decreasing the central transmission of mechanical pain signals. I will provide the first evidence that following spared nerve injury, RGS4 expression is selectively increased in prodynorphin-expressing inhibitory interneurons. Normally, prodynorphin interneurons serve as a brake against amplification of pain signaling by somatostatin interneurons. Because RGS4 terminates signaling in prodynorphin interneurons, the net effect is to release the brake and amplify pain signaling. Chronic neuropathic pain was induced in C57 black 6 male mice via spared nerve injury. The image on the right shows the topographic organization of different pain fibers entering the dorsal horn, which is the region of interest in our study. At 2.5 months post-surgery, animals were sacrificed and lumbar spinal cords were harvested for tissue processing. RNAscope was used to visualize and quantify single molecule mRNA expression. Images were acquired with a confocal microscope, and quantitative analysis was performed using Cell Profiler, which can resolve channels having differing wavelengths corresponding to different RNA probes. This slide is a representative image of the superficial dorsal horn in a sham-injured mouse at 2.5 months. The inset shows RGS4 expression shown in white, somatostatin expression shown in red, prodynorphin expression shown by green, and the 3-channel merged signal is shown in the bottom right panel. This graph shows that at 2.5 months post-surgery, the proportion of RGS4 positive cells in the superficial dorsal horn was significantly increased in spared nerve injured versus sham injured mice. In this slide, white puncta represent RGS4 gene expression. DAPI stained cell nuclei appear in blue, RGS4 expression was significantly increased in SNI versus sham-injured mice. In sham-injured mice, there were no significant differences in RGS4 co-localized expression in somatostatin or prodynorphin-positive interneurons. On the other hand, in spared nerve-injured mice, RGS4 expression was significantly increased in prodynorphin inhibitory versus somatostatin excitatory interneurons. Co-localization of RGS4 together with prodynorphin appears as increased aqua puncta in spared nerve-injured compared to sham-injured mice. RGS4 and somatostatin co-localization appears as magenta. Our hypothesis is that increased expression of RGS4 in prodynorphin inhibitory interneurons may interfere with the sensory gating of nociceptor signaling, resulting in amplification of pain transmission. We also have evidence, as shown in this image, that RGS4 modulates chronic pain at the level of the dorsal root ganglion.
1 minute.
This slide shows increased RGS4 expression in the DRG from SNI versus sham mice. RGS4 expression was significantly increased in the DRG in SNI versus sham-injured mice, and neuronal specific RGS4 expression was also increased in SNI versus sham mice. In summary, I've demonstrated RGS4 expression increases in the dorsal horn and DRG following spared nerve injury in the mouse. I'd like to thank Dr. Zachariou for giving me this opportunity. I'd also like to thank Dr. Margettis and Dr. Steinberger for their collaboration in an ongoing IRB-approved study to analyze RGS4 expression in DRG from patients suffering from chronic radicular or cancer-related pain. Finally, in collaboration with Dr. Tenuver's lab, I'm using RNAscope to analyze SARS-CoV-2 viral expression in the dorsal root ganglion, spinal cord, and several brain regions in a hamster model of acute and chronic COVID infection. Thank you for your attention.
Thank you, Dr. Zimmering. We have time for 1 or 2 questions.
Jeff, what is the thinking behind the SARS-CoV-2 study?
Unfortunately, I'm unable to share the unpublished data presently at this time, but I can tell you that we have 2 different...
I just meant the hypothesis driving the study.
Yeah, so we're looking for mechanistically to be able to trace the viral spread and find other putative mechanisms for how the virus enters the brain, how it travels throughout the brain. And in addition, we're interested in trying to further understand if the virus actually enters the dorsal root ganglia and/or spinal cord, which has not yet been demonstrated. And if so, this may be a potential mechanism for some of the neuropathic pain that has been demonstrated in patients with both acute COVID infection and some of the long haulers.
Okay, thank you. Let's move on to the next presentation. This will be by Dr. Jorge Roa. He is one of our pre-residency fellows this year at Mount Sinai. The title of his presentation is Safety and Efficacy of Responsive Neurostimulation in the Treatment of Medically Refractory Epilepsy, a single center 5-year prospective study. Dr. Fedor Panov is the mentor involved with this research.
Thanks, Dr. Hadjipanais, and thank you for this opportunity to present. This is our clinical research experience, a 5-year prospective study with the Sinai summary of RNS for medically refractory epilepsy. As you know, around 30% of people with epilepsy develop drug-resistant epilepsy. And in those cases, either resection or lead therapy can be an option. However, some patients suffer from multiple seizure foci, or the focus is located in an eloquent area, or sometimes the neuronal network is poorly delineated. And for those patients, neuromodulation has been growing up recently as a very good option with VNS and also deep brain stimulation. And in 2013, we had the FDA approval for the RNS, the responsive neurostimulation system, for patients with DRE who have no more than 2 epileptogenic foci. So this is just the NeuroPace RNS system. It has 2 leads, one that goes in the cortex, one that goes deeper, usually in the mesial temporal lobe or somewhere in the basal ganglia, depending on your target. And there is this tray for the neurostimulator device, which can be fixed in the bone with a craniotomy. As you may see in this diagram, this is a dynamic system, bidirectional, which can learn over time. And that's something that differentiates RNS compared to other treatments, such as definite surgery or lead therapy, that the system learns and it can sense when the seizure happens, and it's designed to abort it with stimulation. To date, the effectiveness of RNS to provide long-term seizure control has not been sufficiently studied or assessed due to lack of prospective studies. And that's where our clinical experience comes into place. This is a prospective single-center study. The population was DRE patients who had the system implanted from September 2015 to December 2020 at Mount Sinai Health System. The primary outcome was seizure freedom and complications. A multidisciplinary conference was designed to evaluate each patient, and all of them had either cortical grids or strips placed or stereo EEG to make sure we had reached the right target. Seizure outcomes, all patients had a follow-up of at least 6 months after the device implantation. And in some cases, we had to review the medical history from the medical charts for demographic variables mainly. We classified outcome in 4 different categories: 75 to 100%, including seizure freedom response, 50 to 74%, 25 to 49%, and 0 to 24%. The implantation technique, we use the ROSA robot. For most patients, we have MRI contrast studies to assess our right target. And with the robot, we implant the deep electrodes, the deep strips. And this is what the craniotomy side looks like with the device implanted. All this information from the device gets into a cloud network, which shows us how many times the patient has firing depolarizations in the network, and how many times the system has been stimulated enough to discharge. In terms of outcomes, 103 patients over those 5 years underwent a RNS placement. Of them, almost 50% were women. Mean age was 27.2 years old. The average follow-up was 20 months with a standard deviation of 13, and 74 patients had a 6-month or higher follow-up available. This is our outcome. As you may see, almost 70% of patients had 50% or more response to their RNS therapy. Of note, some of these patients had already had a VNS or resection surgery before. In terms of complications, we saw infection in 4 cases. Of those, only 1 required revision of the RNS system, and 1 required explantation or removal of it. And 5 patients suffered intracranial hemorrhage. All of them were tract hemorrhages that were not symptomatic. No strokes, no device malfunction, no device migration. And we were able to reach a 1 millimeter,
1 minute,
1 millimeter target difference. Variables associated with success or worse outcome. We saw that patients with the slits in the mesial temporal lobe had a better response, and variables associated with the worst outcome: younger age, syndromic etiology of the seizures, failed response to 5 or more anti-epileptic drugs, and prior surgical intervention. As conclusions, RNS implantation achieved 50% or more seizure control in 70 or so percent of patients. Infections and tract hemorrhage are the most common complications, and seizure freedom may be significantly lower in patients with aggressive epilepsy syndromes since a young age, and those who have failed 5 or more anti-epileptic drugs or had prior surgical interventions. Thank you so much for your attention. I would be more than happy to take any questions you may have.
We have time for one question. Thank you, Jorge.
Hey, Kostas, this is Jay. All right, I have a question. You listed in the beginning that this was prospective. Can you speak on that? I think I'm not sure that the design really meets requirements for a prospective study.
Yeah, thanks for the question, Dr. Moko. Strictly, it does not. What has been collected prospectively is the outcome mainly, which means how many patients have responded to the RNS system. But we did have to take a look at the charts for demographic variable collection.
That's fine. I would just advise you that wouldn't meet the technical definition of a prospective study. So
yeah, Jay, I'm sorry, that's my fault. Yeah, we should phrase this as retrospective.
As retrospective.
Retrospective review of a prospectively maintained database.
Thanks. Since all data in the medical record is put in the medical record prospectively, you could say that for every study. So you really should just call it retrospective.
Thanks.
Thanks, Jay. Okay, we're going to move on to our next presenter. Thank you, Jorge. Our next presenter is Stavros Matsoukas. He's a research assistant. He's a medical student from Greece, spending the year with us. His mentors, Dr. Joanna Fifi. The title of his presentation is Accuracy of an Artificial Intelligence Algorithm for Detection of Large Vessel Occlusion on CT Angiography on a Real-Life Retrospective Patient Data Set, a Diagnostic Test Accuracy Study. Stavros, can you share your presentation with us? Thank you.
Sure. Can you see my screen?
Yes.
Thank you, everybody. So I'm a medical graduate from Greece, as you know. I'm working with Dr. Fifi in a research position. I'm interested in applying for neurosurgery. So during my this research year, one of the main studies that we did is that we calculated the accuracy of an artificial intelligence algorithm, which is used by our hospital, and it's been implemented since May 2019, and what it does, it actually detects a large vessel occlusion on a CDA imaging. So a little bit of the background. So stroke serves as the 5th leading cause of morbidity and mortality in the United States. And we know that mechanical thrombectomy for elbows is an effective treatment, but it's time sensitive. So we need a well-trained eye for CDA interpretation by radiologists who might not always be available. We know that missing elbows can result in preventable morbidity and mortality. So we have implemented this application in our system, in our hospital system, but we currently don't know its accuracy to detect large vessel occlusion. So what we did, we went and we calculated the accuracy of this algorithm to detect large vessel occlusion, and we assumed that as a triage tool, it should have high sensitivity and high negative predictive value. Our methods included gathering all stroke codes since VisAI was implemented in our hospital. That was from May 9, 2019 until November 2020 when we gathered the data set. We have all levels of care in our health system, including primary stroke centers, thrombectomy-capable stroke centers, and comprehensive stroke centers. For the purposes of our study, VIS served as the index test and CDA served as the reference test. We had to include only part of the anterior circulation large vessel occlusions, specifically ICE terminus occlusions, M1 and M2 occlusions. And this is because the VIS application is calibrated to see only these occlusions. So therefore, we excluded all the other occlusions, and we also excluded a few non-diagnostic CDAs. So baseline characteristics of our population, mean age was 72, half of them were females. We had 11 ICA terminus occlusions, 76 M1 occlusions, and 55 M2 occlusions. So overall, there were 1,827 stroke codes called and read by Viz. Out of them, 1,600 weren't occlusions by CDA. All the other were occlusions, and we had 142 IC terminus M1 and M2 occlusions, and we excluded the rest 83 occlusions. Now, if we ask the question, if we have a specific occlusion, IC terminus M1, M2, how many of them does the VIS-AI pick up? So it turns out that for IC terminus, the number is 81.81%. For M1 is almost 90%, and for M2 is 50%. That's quite poor. We contacted the company, and they told us that VIS-AI performs better for proximal M2 occlusions and occlusions. There isn't a specific cutoff point. So what we did, we did two different analyses.
One minute.
In the first analysis, we included ICAT and M1. And the second analysis, we include ICAT, M1, and M2 occlusion in the disease population. So for the first group, sensitivity was 87.4, very high negative predictive value, 99.3%, increased positive and negative likelihood ratio, 10.0904, and overall accuracy was 9.11%, and area under the curve was 0.89. Sensitivity was a little bit poorer for the second population, where we included also the M2, because as we said, the algorithm performs worse for the M2. Limitations of our study, every impression was read by a single individual, and we included part of the anterior circulation and large vessel occlusions. Presumably, the algorithm gets better over time, and now they can read proximal IC occlusions. And we have some interesting conclusions from here. We have radiologist comparable sensitivity and NPV, assuming we have an ICAT or M1 occlusion. M2 is currently questionable. It's not applicable for posterior circulation elbows. And positive results need careful interpretation. Since a false positive result could be either stenosis or our next step would be to have the most current algorithm to read all the stroke codes we had so far and recalculate accuracy.
Thank you, Salvador.
Thank you.
We have time for one question. Okay. Just a reminder, we do have a panel of judges scoring the presentation this morning, and we're going to, at the end, we will decide on the winner of the SASGEV Research Day and also a runner-up. Okay, we're going to move on to our next speaker, Michael Martini, who is our third-year medical student. And just, I wanted to highlight an interesting fact. We published a paper this year looking at all our medical students' presentations, and well, we're in the top 6 of productivity in terms of publications by medical students. So we are proud of the work they're doing, and you'll get a good taste of that today with the research. So Dr. Panoff and Dr. Gatan are the mentors here, and the title of the presentation from Michael Martini is Deep Anomaly Detection of Seizures with Paired Stereo Electroencephalography and Video Recordings, Inspiration from the Mars Rover Curiosity.
All right, thank you very much, and good morning, everyone. My name is Michael Martini. I'm an MD PhD student entering my final year, and will be applying into neurosurgery this coming cycle. Today, I'm going to present on some recently published work involving multimodal seizure detection with paired stereo EEG and video, using a novel workflow inspired by methods employed by NASA in the Mars rover Curiosity. So currently, patients with drug-resistant epilepsy requiring localization of their epileptogenic foci typically undergo intracranial SEEG lead placement, followed by continuous monitoring in the epilepsy monitoring unit, or the EMU, for abnormal seizure events, which can be time and resource intensive to detect. So prior deep learning-based solutions to automated seizure detection have primarily required fully recorded EEG recordings and output the frames with predicted epileptic activity. These approaches have several limitations, however, including limited capacity for real-time predictions, the requirement of large data sets, annotations, and manual pre-screening for artifacts, as well as high false positive rates, all of which can limit clinical utility and are time and cost prohibitive. Thus, we sought to adopt a novel automated framework that circumvents these limitations by creating individualized patient-specific models requiring only minimal data for training, no manual annotations, and with the capacity for near real-time predictions with reduced false positive rates. And we did this by adopting a novel framework proposed by NASA's Jet Propulsion Laboratory that allowed the Mars rover Curiosity to detect anomalies in real time on the Martian surface from its individual data recording streams, a process that we felt was actually analogous to seizure detection in individual patients. And a fun fact is that this approach even helped Curiosity detect and evade Martian sandstorms, such as the one that doomed the previous rover Opportunity. So for this study, we basically obtained continuous in-hospital SEEG and video recordings from 14 patients with drug-resistant epilepsy in the EMU, pre-processed their recordings and input them into this novel framework, and all results were compared with the readings of epileptologists. So first I want to walk through a representative case to kind of highlight this framework before proceeding with the final cohort results. So basically, this is a 23-year-old female with hypermotor seizures who underwent monitoring. On the right, you see the sequence used to train the network, which included 2 anomalous events shown in red. In blue here, you can see the model predictions overlying the actual data in orange. And as you can see, there's a good fidelity everywhere except for one point, which is shown by an elevated error at the bottom, which represents an anomalous predicted event. This schematic compares dynamic versus static thresholding applied to the calculated error over time, which is used in the decision function to determine if a real event is eventually called. The dynamic threshold in pink, which adjusts for the local area in a sliding window approach, is better able to prevent false positive predictions, but still correctly identifies true positives compared to the static threshold in blue, which has many more false positives in comparison. To assess the patient specificity of our models, we also performed crossover studies to see how a model trained on data from one patient is able to perform when tested on data from another. As you can see in this example, doing this crossover study results in a significantly worse performance with many more false positives, suggesting that the learned latent representations of each SEEG recording during training are in fact patient-specific. We next assessed the utility of integrating concurrent video recordings with the experimental setup illustrated here. For the videos, we calculated a regularity score for each frame using a special neural network, and then applied the NASA framework to this signal to then detect any video anomalies. So this plot shows the computed regularity score frame by frame for a video with spikes in the error, again correlating with some sort of anomaly. As you can see, although the seizures were detected, the videos were riddled with many non-seizure events that looked anomalous compared to the patient's baseline, such as when nurses came by or if the patient was eating. And this table shows all of the combined data across all the patients in our cohort. So dynamic thresholding increased the sensitivity and decreased the false discovery rate compared to traditional static thresholding approaches. Crossover experiments demonstrated to us that dramatic increases in false positive detections suggested that the trained models are in fact tuned to be patient-specific. Anomaly detection in continuous video recordings is noisy, we found, evidenced by a high false discovery rate. But when combined with SEEG recordings, the sensitivity did improve to 100% compared to the roughly 80% sensitivity of the stereo EEG only method. In comparison to a video only method, however, this multimodal method actually improved the positive predictive value from 65% to 65% from 19%. And together we think this suggests potential in the dual monitoring, but that more work should probably be done to optimize this performance. And finally, I want to extend my deep thanks to everyone at AI Sinai, the Mount Sinai Functional Neurosurgery and Epilepsy teams, and the Neurosurgery Department leadership, without whom this work would not have been possible. Thank you.
Thank you, Michael. We have some time for one question. Okay. All right, thank you.
Thank
We're
you.
going to move on to our next speaker, Gabrielle Price. She's an MD PhD student actually in my lab. She will be discussing 5-ALA photodynamic therapy and targeting MEK-ERK signaling elicits synergistic anti-tumor effects in diffuse midline glioma. Gabrielle, are you muted?
I am not. Can
you
everyone
go.
hear me?
We
Okay.
can.
Yes, great. Good morning. My name is Gabrielle Price, and I will be presenting on the synergism of MEK inhibition and 5-ALA and PDT in diffuse midline glioma. DMG is one of the most aggressive pediatric tumors affecting the brainstem, spinal cord, and thalamus. It bears a bleak prognosis with a median survival of 11 months, and even when treated, only 10% of patients survive 2 years from onset. DMG arises from postnatal or embryonic precursor cells and has vastly distinct molecular characterization. This tumor is diffuse in nature as shown in the histological stain. The mainstay of treatment for DMG is radiotherapy, but this modality marginally improves survival. The two main barriers to effective treatment is one, despite there being distinct molecular alterations between DMG and adult high-grade gliomas, DMG therapy has been derived from extrapolation from adult tumors, and two, the selectively penetrable blood-brain barrier limits systemic drug delivery to the tumors. Because photodynamic therapy is a minimally invasive treatment that targets cancer cells, it can be a potential therapy for DMG. PDT involves the delivery of a photosensitive agent, in this case 5-ALA, that is metabolized to protoporphyrin in combination with light at 635 nanometers. Light activates protoporphyrin through the transfer of energy that then results in excitation of molecular oxygen to a singlet state where the energy causes fluorescence, or a triplet state where the energy generates cytotoxic reactive oxygen species necessary to induce cell death. There are a number of ways to accumulate protoporphyrin in tumor cells and enhance the efficacy of PDT, one of which is through inhibition of MEK signaling, which has been implicated in tumorigenesis. Inhibition of MEK has been found to accumulate protoporphyrin in select carcinomas by one, downregulation of a cassette in the cytosol that mediates protoporphyrin efflux, and reduction in ferrochelatase activity that converts protoporphyrin to heme. Because MEK inhibition can accumulate protoporphyrin in tumor cells, and 5-ALA and PDT can reduce tumor burden while sparing normal tissue, inhibiting MEK with 5-ALA and PDT has the potential to be a promising, minimally invasive treatment for DMG. Therefore, my aims are to assess the effects of MEK inhibition and 5-ALA and PDT on cell survival and reactive oxygen species production in cell culture models, and to characterize tumor growth and survival analysis of the DMG transgenic mouse model. My in vitro in vivo approaches are on the right. The selective accumulation of protoporphyrin is critical for the therapeutic success of 5-ALA after it's administered, and this accumulation was confirmed by confocal microscopy. So the 5-ALA, upon incubating with the DIPG cells, you can see a fluorescence because there is protoporphyrin accumulation. And so DIPG cells, a subgroup of DMG, developed high protoporphyrin signals when incubated with 5-ALA. 5-ALA and PDT decreased cell viability in a dose-dependent manner at sub-millimolar concentrations. And it was interesting that at DIPG4, the only cell line with an H3.1 histone mutation had the lowest IC50, which suggests there may be intertumoral differences in response to treatment. There was a concentration and time-dependent decrease in cell viability when treating cells with MEK inhibitor trametinib. And the Western blot confirmed the induction of apoptosis via caspase 3 and knockout of MEK via phospho-ERK. The combination therapy reduced cell viability compared to 5-ALA and PDT or trametinib alone. And the Shao-Telele median effect method uses a combination index to define the nature of drug interactions. The index of combination treatment was 0.137, which indicates synergism. And we also found that the combination induces programmed cell death in these cells through the generation of reactive oxygen species.
1 minute.
We then used an allograft DMG model where we injected cells cultured from tumors from a DMG transgenic mouse model. The transgenic model recapitulates factors that DMG secrete and consists of main oncogenic drivers of DMG. We then characterized tumor growth upon injecting these cells. All mice grew tumors within a reasonable time frame, proving this to be an effective in vivo model. The tumor histology from the transgenic mouse model demonstrates features of DMG, including microvascular proliferation and pseudopalisading necrosis, as you can see on the left. And we then conducted an experiment to see if administering 5-ALA and the laser light had any effect on the mouse brain. There was slight punctate staining that resembled the apoptotic marker cleaved caspase 3. And then we saw densely packed cells stained with Ki67 in green to delineate the tumor. So in summary, 5-ALA and PDT and MEK inhibition has anti-tumor effects in vitro, and there may be intertumoral differences in response to combination treatment, and 5-ALA and PDT induces programmed cell death in vivo. I have my future directions listed below as well. I would like to acknowledge my lab, specifically Dr. Haja Panayas, my thesis committee members and collaborators, as well as MSTP leadership.
Thank you, Gabrielle. Any questions for Gabrielle?
I have a question. I'm sorry, I missed your future directions slide. It's just, I guess my question is, where do you hope to take this next?
Sure. My future directions are to confirm the knockout of MEK and the combination treatment and the induction of programmed cell death in vitro, and to study the impacts of the combination therapy on lifestyle dynamics such as migration and intravasation, as well as to sort for 5-ALA fluorescence to separate the invasive tumor cells, and evaluating ferrochelatase expression in the DMG cell lines compared to a healthy brain, and then conducting in vivo survival experiments to test the combination.
Excellent work. Thank you.
Thank you.
Thank you, Gabrielle. Okay, so we're going to keep moving. So our next speaker, who is also a medical student, Roshini Kalagara. She is a first-year medical student. Her mentor is Dr. Chris Kellner, one of our faculty members on today. And the title of her presentation is Remote Patient Monitoring and Blood Pressure Management, a Systemic Review and Meta-Analysis.
Hi, can you see this okay?
We can.
Hi, my name is Roshini Kalgara, and I work with Dr. Kellner, and my project is titled Remote Patient Monitoring and Blood Pressure Management, a Systematic Review and Meta-Analysis. I have no conflicts of interest to disclose, but Dr. Kellner and Dr. Petrino are in the process of developing a remote patient monitoring commercial product with Mount Sinai. In this study, we explore the link between hypertension and stroke. Hypertension has been identified as an important modifiable risk factor for all types of stroke. Importantly, intensive blood pressure treatment has significantly reduced stroke recurrence by 22%, which is especially important in our patient population of people with past history of stroke. Moreover, blood pressure is a very dynamic value, and a single clinic measurement may not be the best way to monitor this. So we were exploring the relationship between telemedicine and hypertension management. Recently, telemedicine has been emerging as an important technique for chronic disease management, and we wanted to see the role of telemedicine in hypertension management. So the aim of this study was to survey literature that has used web or mobile application-based remote patient monitoring techniques for blood pressure management. Here's an example of the search criteria we used when querying the databases. In general, we were looking for 3 things when we were constructing these searches. The first was it needed to include some kind of self-blood pressure monitoring technology. The next, it needed to have a web or application-based telemedicine technique. And third, it needs to be a randomized control trial or include some kind of intervention group and a control group for data measurement. So here's a sample of what we did in this study. In total, we identified approximately 1,200 studies, and we included 18 after doing a title and abstract screening and a full text assessment. Here are the results of the studies that we found for this paper. And in total, as you can see, they come from 2009 up until 2020, with more being recently with the advent of more technologies being developed. So the first graph I'm going to show you is a change in systolic blood pressure effect sizes, and following I will show the diastolic blood pressure effect size changes. So in here, the mean change in effect size was 1.1, which corresponds to 86% of the control group having a lower systolic blood pressure change than the average member in the intervention group. Another important thing to note here is the level of heterogeneity present in these samples. Next, we have the change in diastolic blood pressure effect sizes. The mean change in this effect size is 0.98, which corresponds to 84% of the control group having a lower diastolic blood pressure change than the average member in the intervention group. Once again, we experience moderate heterogeneity in this sample. In conclusion, we can see that web and mobile application-based remote patient monitoring programs were associated with an overall decrease in both systolic and diastolic blood pressures. Individual programs differed in study design, which may explain the varying BP changes we saw and the levels of heterogeneity that we saw in our samples. In the future, we want to explore these themes a little bit more and look into a qualitative analysis into the design factors that created more or less significant blood pressure changes. We want to incorporate these themes into our precision recovery program and be able to also establish targets for blood pressure improvements for both us and our patients. Thank you. Any questions?
Thank you, Roshni. Nice job. I had a quick question. Where else do you see this going? I mean, blood pressure is really interesting and your data is showing that you're having an effect, but what other things can we monitor and see changes with this type of program?
Yeah, I think another thing that we can monitor is potentially like mental assessment scans. I think Dr. Kellner has been previously working on this using like video technology, and I'm sure he can speak more about that too.
You know, obviously our focus is on stroke recovery, and monitoring the neuro exam at home is a challenge, and we're using automated video assessment of a weekly guided neuro exam. But then another remote monitoring feature that would be very helpful is intermittent cognitive testing. And there are now a few applications that do remote cognitive testing using a web-based app. And it's standard tests that have been digitized. And so the combination of those three things make up the core of the precision recovery program.
Nice. Okay, we're actually right on time. So we're doing well here. All right, so we're going to move on to Trevor Hartigan, one of our residents. His mentor is Jay Mako, and the title of his presentation is Ever Run Trial, Endovascular Therapy versus Microsurgical Clipping of Ruptured Wide Neck Aneurysms, a Multi-Center Prospective Propensity Score Analysis.
Hi, good morning. Thank you for giving me the opportunity to present our research today. This registry was started with Dr. Mako and Dr. Justin Massatelli, who has been at all three of the institutions you see below, and this is a multi-center trial amongst these three institutions. These are the full author list as well as all of our disclosures. Won't belabor these at the moment. So wide neck aneurysms is the focus of this study. As we know, with ISAT as well as the barrel ruptured aneurysm trial, that RCTs have demonstrated superiority of endovascular therapy compared to microsurgical therapy in the treatment of ruptured intracranial aneurysms. But whether or not these apply to the full subset of aneurysms remains to be determined. A post hoc analysis in the BRAT study demonstrated similar clinical outcomes between endovascular therapy and microsurgical therapy in ruptured wide neck aneurysms. So this registry was designed to prospectively evaluate EVT and microsurgery with rigorous outcome assessments following ruptured wide neck aneurysm treatments. We felt that there was likely to be a benefit of endovascular therapy for ruptured aneurysms that would be the same as microsurgical therapy, given the challenges of endovascular therapy for wide neck aneurysms, namely including the risk of dual antiplatelet therapy. So as I said, this is a multi-center trial. We enrolled over a 2-year period, and aneurysm treatment was determined by each treating center. So we enrolled 290 patients overall in an entire study, which incorporated 310 wide neck aneurysms. Of those, 87 were ruptured, 223 were unruptured. We treated them both with microsurgical techniques as well as endovascular therapy, and the EverRun registry was developed out of our ruptured grouping, which I'm presenting the data here today. Inclusion criteria was ruptured wide neck aneurysms. The determination for how we defined wide neck aneurysms is demonstrated here. It's either a dome width greater than 4, and either diameter, a dome neck greater than 4, as well as a dome to neck ratio that could be less than 2 in multiple orthogonal directions, and a dome height or largest diameter greater than 4 millimeters, as demonstrated here. This is the same that we used during the barrel ruptured aneurysm trial that Dr. Massatelli was involved in. Our main outcome was MRS at 1 year post-treatment, and we had secondary outcomes, including MRS of discharge, retreatment, as well as angiographic rates. Our statistical analysis between the groups was done with propensity score analysis to deal with some of the inherent issues of an observational study, which we'll describe. So our results show that our baseline demographic info was very well matched between our 2 groups overall. There was not a significant difference in any of these determinants, including Hun-Hess grade, ICH, or IVH between our groups. For aneurysm, the aneurysm criteria and characteristics, some interesting things that we observed was that between the 3 sites, that location was significant, namely that anterior circulation aneurysms, specifically the MCA aneurysms that we observed, were more likely to have microsurgical intervention. There were no microsurgical ruptured aneurysms that were treated in the posterior circulation, which was also a very interesting finding, and I think shows the power of some of the endovascular techniques to handle those. Dome height was significantly higher in endovascular treated aneurysms as well. Other associated findings like bifurcation sidewall aneurysms or the dome to neck ratio, as we stipulated, were not different.
1 minute.
All right. This is just some procedural information showing there was no real procedural complication or other differences. Medical complications were also not statistically different in our group. This is a propensity score analysis showing that there was no difference between our groups. And most importantly, we showed that there was no change in our 1 year follow-up for MRS between our groups here. We also showed that there was an increased incidence of retreatment in our endovascular group. So some limitations of our study. We had non-equivalent treatment cohorts as a result of the institutional bias. There were some angiographic differences between how we handled them that I'd be happy to discuss in regards to their follow-up. We also did not include any novel EVT treatments like Weber, Comaneci, but this is a very powerful registry format that was done at multiple academic centers using propensity score analysis. So in conclusion, I'd like to say that these wide-neck aneurysms, because of their challenging anatomy, are a population that, while endovascular therapy was previously demonstrated to be superior, it might not be the case for these, and microsurgical treatment is also equally effective. So further investigation is warranted, and I'd like to thank the rest of our team here, including Dr. Mako, the principal investigator of the study. Be happy to take any questions.
Yeah, we have time for one question. Thank you, Trevor. We have a question here from Neha. Are you extending or combining this registry with other aneurysm registries?
So the extension of the study isn't something that we're currently looking at right now. However, the results of our unruptured data sample, as I said, which was over 200 aneurysms, will also be published. I believe that Dr. Massatelli might be coming to give a talk on that at some point soon. But we would certainly be willing to expand on this work with other aneurysm registries. I think that the registry data really shows the power of this particular type of study.
Okay. Thank you.
Thank you.
Okay, our next presenter is Jonathan DeLee. He's a first-year medical student at Mount Sinai. His mentor is Dr. Raj Shrivastava. And the title of his presentation is Pole Mutant Meningiomas Associated with Increased CD8 Cell Infiltration and Prolonged Survival.
Hello, my name is Jonathan DeLee, and I'm a first-year medical student who works with Dr. Shrivastava. Today, I'm going to talk to you about some of our meningioma genetics work, specifically our finding that pole mutant genotypes associated with both CD8 infiltration and prolonged progression-free survival in meningiomas.
Jonathan, can you go to presentation mode? Do you mind?
Oh, I apologize. Yes.
That's okay. Thanks.
Is that currently in presentation mode?
No, it's not. I think
Oh.
it's, yeah, there you go. Oh,
Sorry about that.
it's okay.
Is that working now?
Yes, it is. Thank you.
Great, sorry. So meningiomas are the most common intracranial neoplasm diagnosed in the United States, with about 30,000 diagnosed annually. While these can be somewhat homogeneous in appearance, there's certainly quite a bit of genetic and outcome heterogeneity. Classically, meningiomas are classified as grade 1 to grade 3, with generally worsening oncologic outcomes with increasing grade. WHO score is not, however, entirely predictive of these oncologic outcomes, and there are certainly distinct subsets of low-grade meningiomas that do recur. With this in mind, further pathological classification is needed to better predict outcomes and to inform future treatment modalities. There has been recent interest in the impact of immune modulation in meningioma behavior, partly due to a couple of recent case reports demonstrating potential for immunotherapy in meningioma treatment. So to further explore this relationship, the tumor genetics and immune response, we first sequenced 224 grade 1 and 2 meningiomas resected here at Sinai. We then stained for the presence of CD4 and CD8 cells and quantified the degree of immune cell infiltration in this subset of 24 tumors. And next we used ANOVA to assess for the relationship between specific genetic markers and the degree of immune infiltration seen on histological staining. For a specific gene that we identified as related to CD8 infiltration, we explored the relationship to progression-free survival using Kaplan-Meier analysis and Cox regression. So in our cohort of 24 patients who were IHC stained, the average age was 60 and this was 59, and this is similar to that in the whole cohort. And across all measures checked here, the IHC stain cohort was reasonably similar to our whole cohort of analysis. On average, there were 43 CD4 cells seen per high-powered field and 70 CD8 cells seen, so slightly more CD8 cells than CD4 cells. And now onto our ANOVA analysis. I'd like to draw your attention to a specific finding from this analysis. Here highlighted in pink, you can see that the POL mutation was associated with an 82% increase in CD8 cells from 54 cells to 98 cells seen per high-powered field compared to wild type. And then after adjusting for grade and recurrent status, this was a significant result with a p-value of 0.02. Now, to assess the clinical importance of this mutation, we showed to be associated with CD8 infiltration. We performed Kaplan-Meier analysis, which can be seen on the left, and a multivariate Cox regression model on the right to model the impact of the mutation on progression-free survival as defined by stability on serial imaging. The univariate Kaplan-Meier analysis was not statistically significant. However, after adjusting for sex, grade, and primary versus recurrent status, we found that the POL mutation was associated with a 41% decrease in the hazard of progression as defined by serial imaging or stability on serial imaging. This was, again, a statistically significant result. Interestingly, these results were more pronounced in grade 1 tumors in the stratified analysis, where there was a 69% decrease in hazard of recurrence for the grade 1 tumors seen on the left here. This relationship was not seen in grade 2, and further investigation is certainly needed to understand the reason for that. So on to some conclusions. So POL is a DNA repair polymerase DNA polymerase involved in DNA repair pathways. We demonstrated a relationship between this mutation and improved survival or improved oncologic outcomes, specifically in grade 1 meningiomas. A similar relationship to this has been shown in other malignancies such as endometrial cancer, colon cancer, and glioblastoma. So with this in mind, we think this is a true biological effect and propose the following mechanism based on those mechanisms seen in the other malignancies previously mentioned. We think that mutation in this DNA repair pathway results in hypermutation and thus a greater generation of immune-reactive neoantigens. These neoantigens are subsequently presented on MHC1 complexes, which result in greater cytotoxic T cell reactivity. This immune-regulated cytotoxic effect is what we think prolongs survival or recurrence-free survival. Excitingly, we think this work provides further evidence that immunotherapy could be used to target high mutational burden meningiomas, such as POL meningiomas. Recent case reports have shown this to be the case in similar tumors. So in a similar tumor with a similar mismatch repair defective genetics, there was a reasonably profound demonstrated anti-tumor response to an anti-PD-1 antibody therapy. And this is a therapy that enhances the cytotoxic killing of neoplastic cells. These results, specifically the POL mutant results, are confirmed in larger prospective studies. POL mutation may find utility as a screening test to prognosticate on potential for response to immunotherapy. So next steps will include exploring this relationship in a larger sample of IHC stained tumors to try to understand maybe some more subtle interactions between genetics and immune response. And another exciting direction would be a prospective trial of checkpoint inhibitors for high mutational burden meningiomas, such as meningiomas. So with that, I'd like to thank all my collaborators, Dr. Shrivastava, Jack Rutland, Dr. Umflett, and I'd like to take any questions if you have any.
Jonathan, we have time for a question or two.
I have a question. I saw in one of your tables, you looked at the NF2 mutation as well. Was there any correlation between those types of tumors versus mutational burden versus your results?
Sure. So in this, we interestingly saw a decrease in mutational burden, or in CD4 infiltration in the NF2 mutant tumors, which is not what we expected. So certainly further investigation is needed there.
Interesting. Good work. Thank you.
Jonathan, well, I had a question. Oh, Dolores, you have a question? Go for it. You're on mute. You want to unmute, Dolores?
Sorry. So great talk. Thank you. So I'm just curious if you looked at MSH2, MSH6 mutation, because poly sometimes co-occurs with this. So to see in generally, if you did the whole genome sequencing in your 225 samples, how many of them had MMR, other gene mutation, how many had co-occurrence with poly?
So I didn't specifically look at that, but you certainly are correct that MSH2 mutant tumors have shown response to immunotherapy, so that's something we should certainly look into, and we could do with the current data.
Okay, great. All right. Oh, go ahead. You have a question?
Was a quick question. Do you have a plan, or did you assess actual levels of hypermutation in your tumors?
Yes. So if we look, this is I guess it's not included in the backups, but yes, there was a statistically significant increase in the number of mutations across. So we only looked at 96 marker genes. So there were greater number of mutated marker genes of those 96 in full mutant compared to non-full mutant tumors.
So I'll just make one quick comment. So sort of the follow-up answers to the questions are actually in a upcoming publication where we talk specifically about those high mutational burden meningiomas as well. So we'll have more to come for that. Thank you. Good job, John.
Thank you. All right. Our next speaker is Matt Carr, one of our neurosurgery residents. His mentor is Dr. Konstantinos Margetis. The title of the talk is Ultra Early Decompression of Spinal Cord Injury May Improve Outcomes Without Increased Morbidity.
Great. Thank you all very much for allowing me to speak today. As mentioned, I'll be presenting on clinical research I've done with Dr. Margetis and Dr. Hickman, looking at ultra early decompression of spinal cord injury and the impact on neurological outcomes. We have no disclosures. So some background, which I'm sure most of you know, traumatic spinal cord injury is a leading cause of morbidity worldwide. In the United States alone, the annual incidence is about 40 per million people, with annual healthcare costs in the United States of over 7 billion. And that was from data from a couple decades ago. So it's possibly even more now between initial hospitalization and surgery, prolonged rehab, and then the significant sequelae of traumatic spinal cord injury, some of which are mentioned here, which leads to sort of a continued personal and public health burden following the injury. So obviously, given the high prevalence of traumatic spinal cord injury and the significant burden on individuals, it's been an active area of research for some time. Surgical decompression of traumatic spinal cord injury has both at the bench and at the bedside showed to improve neurological outcomes. However, the timing of surgical decompression still remains debated. About a decade ago, the Staskis trial came out and showed that early decompression, which they defined as within 24 hours from surgery, led to improved neurological recovery in patients with traumatic spinal cord injury at cervical levels. And since then, some more recent data showed that there's possibly even earlier targets that can lead to improved outcomes. A meta-analysis last year in World Neurosurgery showed that urgent decompression, they defined as less than 8 hours from injury, had even improved results compared to the 8 to 24 hours cohort. And in other pathologies of sort of central nervous system injury, less than 24 hours would not be considered early decompression. And on TBI patients, especially subdural hematomas, we aim for less than 4-hour decompression. So we believe that time is brain and time is spine. So we sought to determine whether there's an even earlier time target for traumatic spinal cord injury patients, which may see improved neurological outcomes. To that end, we looked at ultra early decompression, which we define here as less than 5 hours from injury. And secondarily, we aim to evaluate if there's an increased risk of complications with ultra early decompression, as that has been a concern with early decompression in the literature. So we have a retrospective case series of patients from Elmhurst Hospital over a 3-year period. And we included all patients who had a spinal cord injury on the Asia impairment scale of grades A through D, who would decompress within 24 hours from injury, or adult patients. We define decompression time in this cohort as the duration between the time of injury from the EMS run report and the time of the surgical incision. And again, we defined ultra early as within 5 hours and early as 5 to 24 hours from injury. A total of 15 patients met criteria for inclusion in the study. The average age was about 49 years old. The vast majority were males, as is often seen in trauma databases, and slight prevalence of cervical spinal cord injury compared to thoracolumbar. And 4 patients here were decompressed less than 5 hours from injury, with a median time to decompression of right about 8.1 hours. The initial AIS grade was pretty well spread out in our patients. The ultra early patients, 3 of which were initially in Asia AIS B, and 1 was a D, and the early patients were more spread out, A, C, and mostly D. The vast majority of mechanisms here were blunt injuries, or they were all blunt injuries. The vast majority were falls, with a couple MVCs. And the injury severity score for these patients ranged from 6 to 25, with a slightly higher injury severity score in the ultra early group, which I think is an interesting result. And we also looked at the mean initial Asia motor score, so just that motor component. And we found that the ultra early and early groups had pretty similar initial early Asia motor scores, both just above 50. When comparing overall AS improvement between the ultra early and early groups, we found that early groups on average saw a 1.25 improvement in Asia grade. So if they were a B going to a C or a D, compared to just under 1 for the early group. However, this value did not reach statistical significance, likely due to the small sample size, underpowered in this study. And you can see there's a sort of greater range of values in the early group compared to the ultra early group. We also looked at Asia motor improvement.
Matt, you have to wrap up. Thanks.
Okay. And again, we saw a slight trend towards improved Asia motor score in the ultra early group. But again, this did not reach significance. There were no intraoperative or postoperative complications directly related to ultra early surgery. And obviously there are significant limitations to this case series, but we do think that there's a trend towards possible improved outcomes, although this is not approached statistical significance, and we do need larger studies to evaluate this. I'll take any questions at this time.
Time for a quick question if we have one. If not, let's move forward.
Thank you all.
Okay, thank you, Matt. All right, our next presentation is by Eslyn DeRizio. She's one of our medical students. Her mentor is Dr. Brian Capel, and the title is Probabilistic Tractography to Understand Connectivity in STN and GPI Deep Brain Stimulation for Parkinson's Disease. Eslyn, can we share your screen?
So sorry, 1 minute.
Okay.
Great, can you see my screen now?
Yeah, can you go to presentation mode?
Oh, sorry. Apologies for that. My computer is having issues currently.
Well, if you can't get to presentation mode, you could just show it the way you did. If that's easier.
That's okay.
Okay. All right. Thank you.
Can you see presentation mode now?
Not yet, but maybe it's coming. There it goes. It's coming now. Give it about 10 seconds here. Oh, we're good.
Okay. So today I'm excited to share my work on structural connectivity for DBS targets in Parkinson's disease. And this is the work that I'm doing with the Center for Advanced Circuit Therapeutics at Mount Sinai. I'm so sorry, not sure why I'm having technical difficulties today. Okay, you can see my screen now, right?
Not yet. It's okay, take a deep breath, we'll get it done. It's all right. There it is, yeah. All right,
okay. Yep. Yeah, so today I'm excited to share our work on connectomics for DBS targets of Parkinson's disease. So this is review for everyone here, but as we know, Parkinson's disease is a motor disorder, typically managed with dopaminergic medications, but over time as the disease progresses, it becomes more and more difficult for patients to remain in the therapeutic window. And so DBS is one such way that we can manage these patients, and it has really good outcomes for their quality of life. And so, of course, we target either the subthalamic nucleus or the globus pallidus interna for DBS. And while targeting and pre-surgical planning is typically based on structures seen on MRI, really the hypothesized mechanism of DBS is working through the stimulation of white matter tracts and targeting downstream structures. And so really, this is an opportunity to improve how we target and how we optimize patient outcomes by taking white matter tracts into account when we target patients. So just a clinical example to show what this can do. So this is a 75-year-old woman with Parkinson's who developed severe microlesion effect after STN DBS. And you can see that she has severe dyskinesias here. And typically the management of this would be retargeting in the GPI. However, by programming the patient such that palidofugal pathways were targeted, in the area activated, we can see that her motor exam is very much improved. And so our goal here was to characterize structural connectivity in STN and GPI DBS patients and use this to better understand and optimize clinical outcomes. So very briefly, we first generated the volume of activated tissue in all of our patients. So this included co-registering and normalizing the MRIs into standard space and generating this volume of activated tissue, or essentially the electric field, in using each patient's specific stimulation parameters. We then used this electric field as a seed for tractography. And so we did probabilistic tractography, and essentially what we're doing here is that we use diffusion tensor imaging, and we're relying on the directionality of the diffusion of water molecules in order to simulate where the white matter tracts are going. And we could be opportunistic here in that we could really isolate the effect of DBS by looking at the net change in UPDRS score between off and on stimulation at one particular time point. So it's naturally accounting for things like disease progression and changes to medication. And so our results, our patients were well matched in terms of disease progression, as well as in their response to medication, which is an important factor in determining response to DBS. And so we generated average maps based on the compilation of the white matter tractography in the individual patients for the STN and GPI patients. And so, in STN, we typically think of this hyperdirect pathway going directly to the cortex. And we're also actually seeing this in our GPI patients. Here we see tracks going up to M1, STN and GPI. We're also seeing a lot of activation or structural connectivity to the cerebellum in both STN and GPI, which is interesting because there's been a lot of work on the dentatothalamic tract and its role in Parkinson's disease and DBS. So next we generated voxel-wise correlation maps that looks at correlation with motoric improvement measured by the change in UPDRS in these patients. And so we see when we threshold for visualization, we see certain areas are activated. So here we see motor regions positively associated with motoric improvement, as well as, again, the cerebellum. And so then we can look at specific areas of the brain. And so here I just, in the interest of time, I'm just singling out the motor areas. And so we do see a significant, albeit subtle, improvement in average connectivity to these areas as UPDRS improves. And so where are we going next with this work? So we're working not only in the motor areas, but we're also—
Thank you.
1 minute.
Thank you.
Someone is in mute, please.
Cortical regions that are connected to the volume of activated tissue in patients with the strongest motor response to stimulation. And then we can run the tracks back in the other direction to look at how we can use this to optimize targeting within the STM and the GPI to further optimize outcomes for these patients. And we're also going to be doing this to look at non-motor outcomes and side effects such as dyskinesia for these patients. So of course, we'd like to thank the department for hosting this today. It's been great seeing everyone's talks and hearing Dr. Liao talk, and I'm looking forward to meeting you actually when I'm at UCLA for a sub-I later this summer. Also huge thanks to CACT for all of the support during this work. It's been really great to work in a multidisciplinary group with this, and happy to take any questions at this time.
Thank you, Ashlyn. We have time for a question. Okay, nice job. Thank you.
Thank you.
Our next presenter is Emily Chapman, who is also one of our medical students who spent a scholarly year in the department. Her mentor is Dr. Jay Mako, and the title is Stroke Center Certification and its Impact on Stroke Mortality in Counties of New York State.
Hi, can you all see this?
Yes.
Okay, great. Okay, thanks for the introduction. It's good to see everybody. I'm Emily Chapman. I'm a medical student here at Mount Sinai, and I'm going to be speaking to you today about Stroke Center Certification and its impact on stroke mortality in the counties of New York State. This is a project I did during my scholarly year with Dr. Mako, working with Kurt as well, and also these students listed here. I have no disclosures. Okay, so oops. All right, I'm going to start by talking about New York State, which has really been a pioneer in stroke delivery systems. Before 2019, the Department of Health was actually in charge of keeping track of all the different hospitals throughout the state and seeing which ones were specializing in stroke care and keeping a running list of them. After 2019, however, hospitals were able to, if they wanted, employ what are known as certifying organizations, I'm going to call them COs, to basically survey and through an extensive criteria list of clinical resourcing and staffing, ideally certify a hospital based on a 3-tier system, which you can see in the graphic below here. The best known CO we're all familiar with is the Joint Commission, but basically by consulting with the TJ and getting approved in this way, hospitals could gain greater state and nationwide recognition. The top tier is Comprehensive Stroke Center. Mount Sinai is a CSC, and that really indicates a really both endovascular and open neurosurgical capabilities for stroke care. At the same time, through previous literature, we have reason to believe that at a nationwide level, at least, stroke care access in terms of stroke certification is associated with the socioeconomic status of the patient population that the hospital serves. So we wanted to see if this was also applicable to New York State. We looked at 123 of their stroke centers, and we tried to see whether there was a relationship between social determinants of health and certification by a CO. We used a variety of data resources for our analysis. We used the US Census for county epi data. We used the CDC for stroke-specific epi data. We used what's known as the ADI, which is a measurement of disadvantage, socioeconomic disadvantage. In this case, higher ADI, so a higher index number is an indication of greater disadvantage. And finally, we used a database of the TJC and the DNV, which are the two most commonly used COs, to keep track of which hospitals had achieved certification status. For our analysis, we created two groups. So the first group consists of counties in New York State that have at least one CO certified center. The second group consists of counties that have no CO certified centers. So we have a CO group and a non-CO group. We then did a between group comparison of social determinants of health. We looked at total healthcare revenue for the county, and we also compared both incidence and mortality rates for the stroke metrics you see here. We tried to see whether we could predict CO certification with these covariates that you see here. And when we ran the analysis, we had some interesting results. Firstly, just about a third of counties in New York State have at least one CO certified center at the time of our analysis. And CO counties had significantly higher median household income, greater population density, lower ADI, so then again, that's less disadvantage, and also lower percentage of self-reported white race. We also found that CO counties had significantly higher average healthcare revenue. And although stroke incidence rates were not significantly different across the different counties, what we did find is that CO counties had lower ischemic, hemorrhagic, and overall stroke mortality rates. These are some heat maps to emphasize the points I just made. In panel A, you'll see that there's a greater density of CO certified centers in the metropolitan area and also the Long Island area. In B, you'll see that the distribution of stroke incidence is, it's some, areas here and there, but more evenly distributed. In C, you'll see that stroke mortality, on the other hand, is concentrated more heavily in the west and north of the state. And in D, you'll see ADI, so again, higher ADI in both the west and northern parts of the state. This map here is blue is CO counties, red is non-CO, and what you'll see is that there's some correlation. We found a significant correlation with greater healthcare spending. Those are the big circles.
1 minute.
Again, specifically in the metropolitan and Long Island areas. From all this data, what we can conclude is that at this point, again, only a minority of New York State stroke centers have gotten the CO certification. Non-CO counties overall had poorer social determinants of health. Non-CO counties had higher stroke mortality despite comparable incidence rates. And finally, in CO counties, we saw greater healthcare revenue overall. At this point, I want to acknowledge Dr. Mako and Kurt for their mentorship and feedback. I want to thank Alice for her GIS mapping, and I want to thank this department for supporting our research and giving me this opportunity to talk today. Thank you so much.
Thank you.
Emily, that was a great talk. How would you use these data to potentially influence policy and how stroke centers are regulated?
I mean, I think, first off the bat, I'm sort of making a case for improving stroke care where demand is greatest, where we're seeing up until now higher mortality rates. It's a little, this is again, of course, an epidemiological study. There are a lot of variables, but I would say that regardless of the specific factors contributing to the high mortality rates, the data is there. And so at least at a start, trying to pump greater resources and really getting the COs to look at these hospitals in these higher mortality rate areas. That would be sort of the top of the list.
Clinical characteristics and paraclinical findings.
Good morning. I'm going to report on our based on our early experience during the COVID-19 pandemic with treating patients presenting with large vessel occlusion. A little background, early on in the pandemic, we had noticed a signal, a 7-fold increase in the number of patients under the age of 50 that are presenting without any prior stroke risk factors with large vessel occlusion. And this report was confirmed with other centers across the world, and Paris saw as well, young people presenting with stroke. And in the early experience in Wuhan, China, 36% of patients being hospitalized with COVID had neurologic problems, and patients who had severe COVID, 6% of them had a stroke, as opposed to only 1% of non-severe. So we wanted to tool this at Sinai and see if there was a relationship between COVID and large vessel occlusion in our hospital system. The study we performed was retrospective, observational in nature. We identified all patients presenting with an LVO to any of the hospitals in the Mount Sinai Health System between March 21st and April 12th, which represents the early peak first wave of COVID in New York City. It corresponds to after New York shut down bars, restaurants, closed schools, closed non-essential businesses. We looked at demographic and clinical factors in patients presenting with LVO. We compared patients who were confirmed COVID positive based on PCR analysis compared to those who were negative. And we also compared to the patients presenting in the exact year prior time period, as well as in 3-week intervals throughout the year to see if there's any difference in the characteristics that we were seeing. In summary, there were 45 patients presenting this 3-week period with LVO. More than half of them were COVID positive. We found that comparing the COVID positive patients to the COVID negative patients, they tended to be younger. They were more likely to be male, and they're less likely to be white. We found that 21% of COVID positive patients were less than 50 years old, compared to 14% in the non-COVID group, which is higher than national reporting standards of age in LVO. When we looked at medical risk factors, we found that surprisingly 46% of COVID patients didn't have any of the classic cerebrovascular risk factors, compared to 24% in the non-COVID cohort. Only 4% had AFib. None of the patients had CHF in the COVID cohort. The patients that presented with a COVID diagnosis that were initially asymptomatic would later on develop symptoms during their hospitalization. And one thing we were noticing was that patients, even if they're asymptomatic, presenting with stroke, 79% of them had some type of abnormal finding on the CTA that would look down to the top of the lung apices. So 42% of patients are basically presenting with stroke as a presenting sign of COVID in our series. We did look at laboratory values for these patients. Nothing too surprising. We found that the platelet count was more elevated in the COVID patients, and greater than 90% of COVID patients had an elevated D dimer, the significance of which we're still learning about. When we looked at the locations of occlusions, it seemed that there's a trend to more proximal occlusions in the COVID cohort. 50% of them presented with ICA occlusions, as opposed to 14% in the COVID negative cohort. And then we looked at the rates of LVO diagnoses within this 3-week period, and we found that compared to the year prior, it was a 2-fold increase. And with regression analysis, we found a giant spike in that week. So in conclusion from what we learned, more than half of the patients that we had seen during the early pandemic were COVID positive with LVO, and they were more likely to be young, male, and less likely to be white. Thank our co-authors for this study, and especially Dr. Majidi and Dr. Mako for all the leadership efforts there.
Thanks, Travis. I had a question. Were you able to look at some of the others' experience around the country that had COVID hotspots in terms of large vessel occlusion, and how your results compared to theirs?
Yeah, there's not enough time to go into all of it, but there have been recent multi-center studies, both U.S., Europe, that confirm some of these findings. But that's a talk for another day.
Great, thanks.
Yeah, I had a question. Because we're kind of seeing similar things in Los Angeles as well. Just these correlations, but do you have any thoughts as to why, these younger patients? I mean, I saw, platelet count, D dimer, but why do you think these younger patients are getting these strokes?
I still don't know, Dr. Lau. there is, COVID can get onto the ACE2 receptor, which is expressed in cardiac, renal system, cerebral vessels. So maybe it's causing some type of heart injury that we're still learning about. There's a hypothesis about a hypercoagulable state in COVID and predisposing to stroke. But I think the community is still learning about that, and I certainly need to learn more about that as well.
Yeah, well, thank you. Interesting.
Thanks. Our next speaker is Halima Tabani, one of our neurosurgery residents. Her mentor is Zach Hipman, and the title of her talk is Efficacy of Anti-Epileptic Drugs and Seizure Prophylaxis Following Complicated Mild Traumatic Brain Injury. Take it away, Halima.
Good morning, everyone. Today I'm going to be talking about our project on the efficacy of anti-epileptic drugs in seizure prophylaxis following complicated mild TBI, and my mentor is Dr. Hickman. So just want to start with a quick recap of TBI. As you know, TBI has been classified into mild, moderate, and severe based on the initial GCS on presentation, the duration of the loss of consciousness, and the duration of post-traumatic amnesia. And this table summarizes the criteria for that classification. Post-traumatic seizures have also been classified into three main categories. The immediate ones being within the first 24 hours, early ones being within the first 7 days, and late ones being after the first 7 days. There have been several studies which have looked into the efficacy of anti-epileptic drugs in preventing early post-traumatic seizures. And based on current guidelines, prophylactic AEDs are recommended for 7 days in severe TBI patients for the prevention of early post-traumatic seizures. However, till date, there's insufficient evidence to formulate clinical practice guidelines for or against the routine use of AEDs for mild or moderate TBI. And this is the group that we were focused on. So our objective was to evaluate the efficacy of prophylactic AEDs in preventing post-traumatic seizures in complicated mild TBI. So we did a retrospective chart review of the trauma registry database at a level 1 trauma center, which is Elmhurst, between January 2017 and March 2019. We included patients who were over 18 years of age and met the criteria for complicated mild TBI, and excluded those who had who already had a history of seizures, were already on AEDs, had a prior history of TBI or penetrating trauma, had a neurological decline to GCS less than 13, or had to undergo any neurosurgical intervention. We collected data on demographics, AED administration type, dosage, duration, the length of hospital stay, and length of follow-up. And our outcome measures were the occurrence of either early, which was within the 7 days, or late, which was over 7 days, post-traumatic seizures. So over this 2-year period, we had a total of 230 patients who met our inclusion criteria, and over 3/4 of those were males. About 20% of those had a history of alcoholism, and around 85% of our patients received prophylactic AEDs. In our cohort, the most commonly used AED was Keppra. All of our patients received Keppra except for one who did initially get Keppra, but was later on switched over to Depakote because she was already diagnosed with another disorder that required her to be on longstanding anti-epileptic. So this table summarizes the demographic features of our cohort. The interesting findings in this table are our average length of stay was less than a week. The duration of AEDs prescribed, the mean duration was 12.4 days, which was over the 7-day recommended duration. And our mean follow-up was about 3 months. However, it was a large range between 0 to 1,050 days. So in our cohort, we found an overall seizure rate of about 2.6%. with 0.8% incidence of early post-traumatic seizures and 1.7% incidence of late post-traumatic seizures. We divided our patients into those who received anti-epileptic drugs versus those who did not. And interestingly, we found that all of our seizures, both early and late, occurred in patients who were in the AED group, so the patients who were getting anti-epileptics. We also wanted to see if there was an association between a history of alcoholism and incidence of seizures. However, we did not find any statistically significant differences in the rate of seizures between those two groups. We did see a higher rate of post-traumatic seizures in patients who had hyponatremia. However, this was also not statistically significant. And also of note, we did not specify, so the hyponatremia was throughout their hospital course. It did not necessarily have to be on presentation.
1 minute.
So to wrap up, the incidence quoted in literature for the incidence of post-traumatic seizures is a very wide range between about 4 to 25%, but most of these studies focus on severe TBI and not mild TBI. So our incidence is lower. However, we have to keep in mind that none of the previous studies were looking specifically at mild TBI. The earliest studies recommended using phenytoin for seizure prophylaxis. However, later studies recommended found that phenytoin and Keppra were both equally efficacious. So more recently, most institutions prefer the use of Keppra, and that's what we found in our study as well. And then the study on the right side was a small study which had a seizure rate of mild TBI similar to our study. And the interesting finding was that they also found that over 25% of their patients received Keppra for more than 7 days. So Keppra was being overprescribed. And all of their patients also had seizures while they were on Keppra. Our study had some limitations based on its retrospective study design. It was a single center study and we only used Keppra as the AED. And given our population, we cannot extrapolate the findings to pediatric TBI patients. In conclusion, our results indicate an overall low incidence of post-traumatic seizures in patients with complicated mild TBI, with all of the seizures occurring in patients who received AEDs and most of the seizures occurring in the late group. So based on our findings, we think that routine AED administration does not appear to reduce the likelihood of either early or late post-traumatic seizures. And these findings may have clinical implications on the administration and duration of prophylactic AEDs in patients with complicated mild TBI. Thank you once again for the opportunity to present, and I'll be happy to answer any questions.
Thank you, Halima. Questions? We have a question from Dr. Dengayech. How do we account for practice variabilities between frontline providers in the use of AED prophylaxis for mild TBI when we interpret the findings of your study? Does the higher incidence of PDS in patients who received AEDs just mean that they have a higher pre-treatment probability of seizures?
Yeah, so this is something that we actually want to look into further. This was one of our hypotheses that we wanted to look at the risk factors. It is very likely that the patients who did get prescribed AEDs were at baseline at a higher risk to develop seizures. So our study was not powered to look into this, but this is definitely something that we are considering to look into further.
It's a secondary analysis that we were going to perform. We collected data from all their head CTs and retrospectively went through those, and also information on who was the prescriber of the anti-epileptic to see if it's just purely a bias from the physician standpoint. Yeah.
Thank you. Okay.
Thank you.
Thanks, Halima. Next presentation is by Nikki Mohammadi. She is a data coordinator research who is mentored by Dr. Christopher Kellner. And the title of the presentation is Remote Patient Monitoring as a Lifeline During the COVID-19 Pandemic, a qualitative study of patients' experiences navigating COVID-19 through the Precision Recovery Program.
Can you see my screen all right?
We can.
Okay, great.
So good morning, everyone. Today I will be presenting a qualitative study we conducted looking at patients' experiences recovering from COVID-19 through the Precision Recovery Program. So some quick disclosures. And then to start, I just want to take us back to the first wave of the pandemic. This is Dr. Matthew Bay reporting on an overflowing ED.
You can see all the rooms are filled. Usually these halls are very neat and empty. And now you can see there's patients everywhere because of this. It makes it very hard to work, and we're trying our.
Looks like it's having trouble loading. So another quick little video from, this one's from Dr. Colleen Smith from Elmhurst.
Had to get a refrigerated truck to store the bodies of patients who are dying. We are right now scrambling to try to get a few additional ventilators or even CPAP machines.
So this is really where the Precision Recovery Program came in. It was created right at the peak of the pandemic to help patients recovering from COVID-19 at home. So any patient concerned about their COVID-19 symptoms could enroll and be paired with a provider for remote patient monitoring of their symptoms. So in our qualitative study, we conducted semi-structured interviews with patients who are enrolled in PR COVID during March and April of 2020. So just a few words about qualitative research. So this is a research method grounded in textual material that aims to document the human experience. So all our data came from interviews where patients were asked about various parts of their experience, including their COVID-19 diagnosis, experience with the healthcare system, and the recovery process. So we conducted 21 interviews with patients, and they were monitored in the program for a median of 35 days, so a little over a month. We had a relatively even split between males and females, and the median age of these patients was 43. We also looked at employment status, residence, and whether patients were living alone or not. So just to delve a little more into the methods, all interviews followed a predetermined interview protocol that was adapted around the conversation. So we opened our interviews by asking patients, tell me more about when your COVID-19 symptoms began. Each interview was recorded and transcribed, and then we conducted a semi-open coding, which involved identifying codes and themes through an iterative process of line-by-line reading. So our research team consisted of 2 reviewers and 1 group leader who collaboratively generated the code book that you see here on the right. All of our data analysis was done in NVivo, which is a qualitative data analysis software. So this is a more macro view of our code book, and we identified 2 main domains, the COVID experience and the healthcare system experience. In discussing the COVID experience, patients expressed feelings of fear, isolation, helplessness, and distress at the general lack of knowledge about COVID. And in the healthcare system domain, many patients described their experience with the Precision Recovery Program and spontaneously brought up issues related to access to care. So our body of interview consisted of over 20 interviews, but here's a snapshot of what one person's data looked like. So as you can see on the graph, testing was 10% of the codes covered in the transcripts, followed by healthcare access and discussions of long-term effects. So I want to talk about a few reoccurring themes, one of which was the theme of testing. Many patients identified the inability to know one's COVID status as a major stressor. So the code testing was present in 17 out of 21 transcripts with a total of 216 references. Testing was identified as a gateway to healthcare. So from patients' perspective, there was no access to hospital care without a positive test. And in the quote below, a patient sort of describes the social ramifications of not being able to be tested, such as having to withhold updates from loved ones. And in discussing isolation, many talked about how this disease is unique because one couldn't be without others and receive tangible support given its infectious nature. So the interviews also yielded quantitative data as well, and this table is an example of that. So we've discussed testing here today, and you can see that only 38% of the patients interviewed were actually able to be tested. So it brings up sort of an important question of how we can best offer reassurance to patients in a similar time.
1 minute.
The last theme that I wanted to raise today relates to the PR program. So patients refer to it as their lifeline, pointing to PR structure as a reason for its success. So the regular check-in system and pairing with a provider gave patients a sense of reassurance during a time of great uncertainty and isolation. And the quote below describes patients' appreciation of the regularity of the program. So in conclusion, this study provides timely insight into the COVID experience and invaluable advice in constructing a roadmap to support future patients in the new healthcare landscape of telemedicine and remote patient monitoring. Thank you.
Thank you, Nikki. Questions?
Nikki, great presentation. Quick question for you about, it makes a lot of sense to have these kinds of programs. So what are, in your mind, the barriers for expanding access to these kinds of programs across the country?
You mean for the Precision Recovery Program specifically? I think having been part of the Precision Recovery team, I think the technology aspect of it could be improved upon a little bit, because I noticed like a lot of the elderly patients, for example, in our population, were having a lot of trouble with this. So I think just making it more accessible to different patient populations would be really helpful for that.
Thank you.
Okay, thank you. All right, moving right along here. We're on talk number 15. So Carolyn Rosea is going to be giving our next talk. She is a member of my lab, going to medical school next year. The title of her talk is an in vivo investigation of intracranial heating efficacy of magnetic iron oxide nanoparticle formulations.
All right, good morning, everyone. Can you hear me?
Yes.
Great. Hi, my name's Caroline Rizia. I'm a member of Dr. Hodgkinias's Brain Tumor Nanotechnology Lab. And today I'm going to be talking to you about the intracranial heating of magnetic iron oxide nanoparticles. Quick background of glioblastoma that I'm sure most of us are familiar with. It's the most aggressive primary brain cancer in adults. Its standard of care involves tumor resection when possible, followed by chemoradiation. Its infiltrative nature prevents total resection, causing tumor recurrence. And this leads researchers like myself to be on the search for new and rapidly evolving treatments, one of which is magnetic hyperthermia therapy, or MHT. MHT is the localized heating of magnetic iron oxide nanoparticles when exposed to an alternating magnetic field. MHT occurs between the temperatures of 42 and 45 degrees Celsius, and this range is really important because anything higher than this could cause damage to healthy brain tissue. We deliver magnetic iron oxide nanoparticles via convection enhanced delivery, or CED. This is a local delivery method that uses an external pump to generate a pressure-dependent infusion. Its benefits are that it's minimally invasive, it's a direct infusion to bypass the blood-brain barrier, and it minimizes systemic toxicity. So how does MHT induce tumor cell death? Well, tumor cells are more sensitive to heat than normal cells are. With nanoparticles present and under the influence of an AMF, MHT can generate shear forces, can increase oxygenation, blood flow, inhibiting DNA damage repair, and chemoradiosensitizing tumor cells. MHT can increase the production of reactive oxygen species, damaging DNA. It can induce caspase 3 apoptosis, and it may induce an immunologic response, which is something that my other fellow lab members are working on currently. The nanoparticles we used for this experiment were at a concentration of 80 milligram per ml. We completed something known as a Ferriin-S assay to quantify the iron. And to do this, we neutralized and diluted our nanoparticles to a concentration of 2 micrograms per ml and compared them to other iron standards. You can see here on the graph, our nanoparticles are that pink dot, and it fell within the standard range. Our methods for this experiment. We used 2 volumes of 6 microliters and 8 microliters of nanoparticles. We delivered them to healthy immunocompetent mice via CED and then placed guided cannulas into both hemispheres. We placed one in the nanoparticle side of the brain and one on the contralateral side where no nanoparticles were present. After CED, we moved the mouse from the stereotactic frame onto the AMF, where we set the settings to 450 kilohertz, 200 Gauss. We inserted temperature probes into both of the cannulas and a third probe into the rectum. These probes completed our temperature measurements, and and we recorded the temperatures every minute for 10 minutes after initiating the AMF. Here's just an image so you can picture what our experiment looked like. Here's our CED on the left and our guided cannula placement on the right. Here's a PET CT of our nanoparticles. You can see the bone defect on the top, which is from our CED needle, as well as the localization of the nanoparticles. Here's just an image of our AMF generators. We've got the controller on the left and the applicator on the right. The controller is where we can set our different parameters, as well as turn on and off the AMF. And on the right is where we place the mouse for MHT. And this is just a detailed image of what our experiment looks like, where you can see the probes in the cannulas as well as the rectum. So for our results, in the 6 microliter volume, we've reached a nanoparticle temperature of close to 45 degrees Celsius. We also had a nice large gap between the nanoparticle temperature and the contralateral temperature. For the 8 microliter volume of nanoparticles, we've reached nearly 50 degrees Celsius, and our contralateral temperature exceeded 45 degrees Celsius, which, if you remember from the beginning, could be damaging to that healthy brain tissue where the nanoparticles are not present. To conclude, our 6 microliter volume reached that desirable MHT temperature fairly quickly after AMF initiation, and we showed no significant heating in the contralateral hemisphere. The 8 microliter volume reached nearly 50 degrees Celsius, and we did exceed that wanted MHT temperature in the contralateral hemisphere. Our next steps are to use our volume of 6 microliters of the 80 milligram per ml nanoparticles for future MHT experiments to complete toxicity experiments in healthy immunocompetent mice, as well as survival experiments in GBM rodent models to determine the anti-tumor effect of MHT in combination with RT and TMZ. This is an example of a mouse GBM model that we'll be using for survival studies, where you could see the growth of our tumors growing over a 20-day span. We actually just injected some of these mice yesterday so that we can start to characterize what the CED looks like of nanoparticles in the tumor. Thank you so much to all of my lab members and especially Dr. Haj Panayas, and thank you to all of you for allowing me the opportunity to present today.
Thank you, Caroline. We have time for a question. Okay. All right. Well, great. Thank you. We'll keep moving on here. Our next presenter will be Eugene Hrabarchuk. I hope I said that correctly. He is one of our first-year medical students. His mentor is Tanvir Chowdhury, and the title of his talk is Imaging Characteristics of Cervical Spondylotic Myelopathy Using Static and Flexion Extension MRI with Novel Grading Scales.
Thank you very much. My name is Eugene Hrabarchuk. I'm a first-year medical student working with Dr. Chowdhury. And today I'm going to be talking about cervical spondylotic myelopathy and specifically how flexion extension MRI could play a vital role in many aspects of this. I also want to thank the neurosurgery department for inviting me to speak today. I have no disclosures. So cervical spondylotic myelopathy, or CSM, is a progressive degenerative disease, and it compresses the spinal cord and also the blood vessels within the spinal cord. On all these cases, MRI is usually taken in the neutral position to determine what levels to conduct surgery. But MRI with in the flexion or the extension position may also help determine canal encroachment in the C-spine, especially earlier than a conventional MRI. There's also some other potentially useful measurements that could help aid in surgical planning that are understudied. That we are studying in this paper, such as cord canal diameter, vertebral translation, disc opening, cord edema, and disc dehydration. So here we show MRI in the flexion, neutral, and extension positions. And here we can see that canal encroachment is more readily visible on the extension position when compared to neutral and flexion. So the goals of this study, which is a foundational study, is to assess whether the flexion extension views are able to predict cervical pathology when compared to just neutral views of traditional MRI. We also created some scales to evaluate the degree of spondylosis, and also we apply these scales to operative and non-operative levels for comparison. So for our methods, there was 45 patients that underwent this dynamic supine cervical MRI prior to a cervical discectomy infusion at specifically levels C4 to C7. And this was a single surgeon between the years of 2001 and 2018. The subjects were 15 men, 30 women with a mean age of 56 years. And we used sagittal and axial T2 weighted sequences for the measurements. We're also very thankful to have Dr. Natick, who spent a considerable amount of time to help perform these measurements. We also conducted intra-rater reliability 2 months after the initial measurements in 20 patients. So specifically in flexion, neutral, and extensive positions, we measured Cobb angles, canal diameter, vertebral translation, and disc opening. In the neutral position only, we measured the disc height, cord contour, cord edema, and disc dehydration. So the next 2 slides, I show you the scales. Some have been previously studied before, but most of these are novel scales, and our criteria are novel. So for the disc height scale, we go from normal to severe loss of height, 0 to 3, and disc opening scale, we go from posterior to anterior. Then we also have a cord contour scale going from normal to severe indentation with sagittal narrowing and edema, 0 to 5. We also have a cord edema scale, which is based on a T2 cord signal change from 0 within normal limits and 3 being severe edema. So for our results, we show that measuring canal diameter at the disc and the midvertebral body levels, there's a significant difference between the operated levels, C4 to C7, and the other cervical levels. Specifically on the disc level on the left, we can see that extension causes a smaller canal diameter to be present compared to flexion. And also for operated levels, we see that there is worse spondylolisthesis for the operated levels compared to non-operated levels on the left. And there is also a worsening of the retrolesthesis on extension. For disc opening, we see that there is more of an open anterior positioning for operated levels compared to non-operated levels. And finally, for our novel grading scales, we see that the cord deformation, the disc height, the cord edema, and the disc dehydration scores were all significant comparing operated levels to non-operated levels. And our intra-rater reliability measurements, anything above 0.75 was considered high reliability. And we see that most of our scales meet that criteria. Even disc dehydration, even though it is below that cutoff, is still good reliability. So in conclusion, this flexion extension MRI has proven to be a good means for possibly capturing the cord compression and earlier than traditional MRI. And specifically using our novel grading scales. So future directions for this project are to assess whether these flexion extension MRIs can predict which levels are more susceptible to adjacent segment disease, which is a large problem after surgery. And then we also want to determine whether this actually affects surgical planning and which operative levels should have an operation, especially when they're borderline. And then we also want to assess the influence of these flexion extension MRI data on the number of levels treated and also the approach. So I want to thank everyone in the lab, especially Madam Lee, who is applying to neurosurgery right now, who spent a considerable portion of his scholarly year invested in this project. And I would also like to thank Dr. Chowdhury and Dr. Natick for their help. Thank you. I'll take any questions.
Okay, we have one question here. Great job. This is by Dr. Dangayich. Wondering how much additional scan time per patient is added with flexion extension MRIs as compared to static MRIs?
Yeah, absolutely. So this is 3 separate MRIs that are conducted. So it does add time to the scan time. But we think it could be very valuable, especially for tracking outcomes and recovery and seeing if this has a clinical meaningful outcome and effect.
Great, thank you.
Thank you.
Our next speaker is Addison Quinones, whose mentor is Dr. Chowdhury. Addison is one of our medical students, first year. The title of his talk is Effects of Sport Contact Level on Baseline Neurocognitive Performance in Adolescent Athletes.
All right, good morning, everyone. My name is Addison Quinones, and I'm a first-year medical student here at Mount Sinai. I'd first like to thank the Neurosurgery Department for giving me the opportunity to present today, and my fellow research group members for their support on this project. So the effects of head trauma have been a hot topic in the realm of sports, and with the help of our research group led by Dr. Chowdhury, we have used a national database to report on how different contact levels in sports affect baseline neurocognition in athletes. I have no disclosures to report. However, one of our co-authors, Dr. Mark Lovell, is a co-founder of Impact, but no longer holds any financial interest in the company. So just to give a little background on head injury, we know that increasing adolescent participation in sports and the focus on long-term health following head injury has led to an increased concern over participation in contact sports. We've also seen that routinely that higher contact sports have a greater incidence of concussions when compared to their lower contact alternatives. And we can actually see in this graph on the right from the period of 1998 to 2008, there's actually been a rise in the concussion incidence per athletic exposures. Whether this is actually due to new head injuries or it's due to better detection and assessment of concussions remains to be seen, but it's just showing that there is greater incidence in athletic exposures. However, even with this increased awareness, previous research on the effects of different levels of contact between sports for baseline neurocognition have shown conflicting results. So just to discuss some prior studies, they usually have limited sample sizes and they also have limited demographics, including things such as age, sex, and years of participation in sports. And it's also worth noting that the previous literature has shown some conflicting results, specifically regarding visual and verbal memory, which are two of the cognitive measures that are assessed in this study. I also wanted to provide some background info on Impact, which is one of the devices with FDA approval for concussion assessment. Essentially, Impact provides a computerized battery of tests designed to evaluate visual and verbal memory, visual motor speed, impulse control, reaction time, and the post-concussion symptom score. And the way Impact is used is that it's administered prior to the onset of a competitive season, and it's also used following any type of suspected concussion. However, in this study, we were only analyzing the baseline results. All right. And the objective of our study was to determine how baseline impact scores are affected by different levels of contact between sports. And just to give an overview of the methods we used for this study, it was an IRB approved retrospective study using data collected between 2009 to 2019. And it consisted of 7,075 student athletes aged between 12 and 18, all having undergone a baseline impact assessment. And we split these student athletes into 3 different contact level cohorts. Those cohorts were the contact collision group, which included sports such as football, lacrosse, wrestling, the limited contact group, which includes sports such as baseball, cheerleading, softball, and the non-contact group, which included sports such as golf, swimming, and track. The entire classification is listed in this table on the right. And then we took the 6 impact scores and we compared them using univariate and multivariable linear regression analyses between them. So this table provides us with the demographics for all 3 contact level cohorts, and we can see that the majority of variables had significant differences between the cohorts, including age, sex, ADHD, history of previous concussions, history of anxiety and depression, and stimulant use. So these differences show why it's important to include more demographic variables, because we are now able to adjust for more confounders than previous studies were able to adjust for. This figure represents the univariate results obtained after comparison of the 6 impact-derived composite scores, with the black bars representing contact collision group, the blue bars representing the limited contact group, and the yellow bars representing no contact. As you can see, there's not a ton of variation in the actual scores between the cohorts, but there are many statistically significant differences as denoted by the asterisks. However, there's no consistent relationship seen between contact levels, and many of these differences are actually washed away after adjustment in our multivariate results, which we're going to see next. So now we're looking at our multivariate results, and we can see by the boxes outlined in red that these results show higher contact levels actually correlate with increased verbal memory, increased visual memory, and quicker reaction time. While the changes represented by these beta values are pretty small, they're still significant, and they actually provide an interesting finding because I think it's more widely thought that a higher contact sport would actually lead to greater deficits, but this suggests that there's not a large decrease in neurocognitive performance with the greater contact sports, at least in adolescent athletes.
1 minute.
So just to wrap up, we've seen how higher contact sports do not appear to result in decreased neurocognitive performance for adolescents at baseline. This study actually shows that there could be a slightly greater visual and verbal memory and better reaction time, although this could also be due to the intrinsic abilities of the athletes choosing to play those specific sports. It's of note that the strength of this study include a large sample size compared to prior studies, and it also includes more demographic variables, providing greater evidence for existing literature. And one limitation that I wanted to mention is that because of the data collection system, we weren't able to account for multi-sport athletes in this data set. And I just want to mention how there is future ongoing work in our lab that's assessing the effects of varying contact levels on post-concussion neurocognitive performance, symptoms, and recovery. Again, I just wanted to thank Dr. Chowdhury and Dr. Alex Schuper and the rest of my lab members for the help on this project. Thank you.
Thank you. Okay, if there's any questions. We have one here. Did you use both ADHD and stimulant in your multivariable model? Perhaps only one of them should be used due to collinearity.
Yeah, we did use both of those in our multivariable model. I guess specifically we didn't have this was all self-reported data, and so some of them may have not reported treatment for ADHD. So that's why we wanted to include both of those variables.
Thank you, Addison. We're in the home stretch here. So our next speaker is Zerubbabel Asfa, who is one of our medical students. Dr. Isabel Germano is the mentor. The title is Racial Diversity within the Neurosurgery Resident and Faculty Workforce in the United States.
All right, could you guys see my screen?
Yeah, can you please go to presentation mode?
Yeah. All right, great. So good morning, everybody. My name is Zerubbabel, and I'll be presenting on racial diversity within the neurosurgery resident and faculty workforce in the US. So we begin by defining underrepresented in medicine. It refers to those racial and ethnic populations that are underrepresented in the medical profession relative to their numbers in the general population, according to the AAMC. And I'm going to use the acronym URAM throughout this talk. So URAM includes African Americans, Latinx, natives, and with the natives, we have Americans, Alaskan, Hawaiian, and Pacific Islanders. And the US Census Bureau and previous research indicates that 50% of the US population is estimated to be non-white by 2045. And especially in the business sector, which has taken on diversity as a priority, recent reports indicate that increasing diversity will lead to higher innovation, varied perspectives, higher profits, and less employee turnover. So for the purposes of our study, we wanted to report the current status of racial diversity in neurosurgery, and this is the first study to do that. We wanted to assess neurosurgery URAM trends within the past decade, and we also wanted to present strategies to improve URAM representation in the academic neurosurgery. All right, so for the methods, we began collecting our data from the ACGME, which contains 115 neurosurgery residency programs. We got our population and geographic data from the Census Bureau and Google, and we used Doximity, NIH, and Blue Ridge rankings for institutional data. When instances where we weren't sure a faculty was URAM or non-URAM, we used their social media profiles in Google to build a consensus among the authors of this study, which was followed by data analysis. So for the results of the study in terms of population trends, broken lines are for general population and solid lines are for the resident workforce. Results indicate that Black and Latinx neurosurgery resident workforce increased by 7% and 28% respectively. However, they only account for 4.8% and 5.8% of the neurosurgery resident workforce. In comparison to the general population, Black and Latinx individuals make up 12.5 and 18.7 of the US population. For residents with a native background, their proportion decreased from 0.3 in 2011 to 0.13 in 2020. So when we compare non-URM with URM between 2011 and 2020, in the general population, individuals who are non-URM decreased from 68% to 66%. However, in the resident workforce, the proportion of non-URM increased from 65% to 73%, which is a paradoxical trend. When we analyzed residents and faculty during 2020, we noted that URM residents make up 10.73% of the resident workforce, while URM faculty make up 8% of the neurosurgery faculty workforce. And this is a statistically significant difference when you compare it to non-URM peers. We asked the question whether faculty size correlated with having more URM faculty members, and it does. We have a significant trend. However, we want to highlight that 33 out of the 115 neurosurgery programs did not have a single URM faculty. That's 30% of the programs in the US. And of these programs, 75% of them, or 25% of them, were large programs that had a faculty size greater than 10. In terms of academic rank, URM faculty tend to be assistant professors at a higher proportion than their non-URM peers. And when we analyze the trends in the hiring of these professors, we note that there are more URM faculty joining the field, which is encouraging. In terms of geographical distribution of programs, we did not find any significant difference based on the geographic distribution of URM faculty. And a top 10 neurosurgery program doesn't mean there are more URM faculty. So even though these programs are highly sought, they're not recruiting more URM faculty. So for our conclusions, we want to highlight that there is ample opportunity to improve URM representation within neurosurgery. In terms of strategies, we want to emphasize that neurosurgeons must engage in mentorship of URM individuals. Department must adopt the Augusta rule, which states that there needs to be at least one woman or URM interviewed for every vacant fac has been working on this project. And we want to highlight our diversity as the following. And I want to give a shout out to Lizzie, who's second in the row. She's the co-first author of the manuscript that came out of this project. And thank you for inviting me to give this presentation.
Thank you, Zerubbabel. That's a great presentation. I think there's a lot of points that resonate with the group. Any questions that we can ask?
I would like to ask a question, make a comment. This paper just, I have to say, it makes me really proud that you guys are doing such amazing work. It's very exciting paper to me. Have you found that there is any correlation with a URM being in a leadership position in a department?
Yes.
That then results in a change in the results?
No, we haven't found that specific result, but we note that all of the URM that ended up in leadership positions were men rather than women. And even though they were like a very small minority from that small cohort, all of them ended up being men.
And so I think another answer, can you guys hear me?
Yeah.
Yes.
Yeah. Thank you. Sorry, I'm in two simultaneous meetings. This is a great question that you're asking. There are only 5 chairs currently that are URM, and they're all men, as Zero said. And in those programs, there is no increased number of URM faculty. Clearly, the N is very small. It's only 5. So we have to see what's happening in the future.
Linda, any thoughts here?
No, great work. Very, very impressive. And I think it's, very eye-opening that, in neurosurgery, we're still not very diverse. I congratulate you for doing this, because I really think it's important.
Thank you very much.
Great talk, Zero. Thank you for all your hard work.
Thank you, Dr. Jamala.
Okay, so moving right along. So our next talk is by one of our first-year medical students, Susmita Chenareddy. Her mentor is Christopher Kellner, and the title is Portable Stroke Detection Devices, a Systematic Scoping Review.
Hi, can you see me okay? See the
yes.
All right.
Hi, my name is Sismi Chen Reddy. I'm working with Dr. Kellner, and today I will be discussing a systematic scoping review about portable stroke detection devices. I have no conflicts of interest, but Dr. Kellner has received research grant support from Cerebrotech, a company that makes one of the portable stroke devices I will be discussing today, and also served as a PI of a multi-center study studying this device. So why is pre-hospital triage important? Severe stroke patients generally require endovascular thrombectomy, and unfortunately, only about 10% of stroke centers currently offer that thrombectomy. And inter-hospital transfer to these more comprehensive stroke centers requires 110 minutes of time delay, which correlates to an almost 40% decreased chance of good treatment outcomes. Currently, pre-hospital triage scales are very used to diagnose and detect and stratify stroke in the pre-hospital setting. EMS systems use this pre-hospital triage scale in order to bypass emergency departments and go to more comprehensive stroke centers, depending on how severe the stroke is. Different areas use different scales, but overall, you can see that the diagnostic accuracy of most of these scales is quite low, as you can see on the bottom of the slide. One way of improving this diagnostic accuracy is by integrating technology, and this has been done in different fields, including in myocardial infarction. So this meta-analysis shows that including electrocardiogram and pre-hospital triage decreases time to treatment for myocardial infarction by about 40%. And this is something that can be paralleled in stroke as well, allowing for pre-hospital diagnosis of stroke, communication with the hospital, and initiation of care, as well as transportation of severe stroke patients to the appropriate thrombectomy-capable center. There are a couple of reviews that talk about pre-hospital stroke detection technology and clinical metrics. Other than that, however, none of these, to our knowledge, are systematic reviews, and this, to our knowledge, is the first systematic scoping review of the topic. So the purpose of the study was to conduct a systematic scoping review about what portable technologies exist to better diagnose or detect stroke in pre-hospital settings. We also want to look at diagnostic accuracy and feasibility of use of the studies, as well as the quality of identified studies. So here are some of the search criteria. I want to highlight a couple of key points. One, we focus on pre-hospital technologies that were either portable or non-invasive and allowed for pre-hospital use. The types of different technology that we covered are in the search criteria itself, but also were found based on previous literature. And we also want to make sure that these technologies detected stroke, and we excluded any studies that did not have any diagnostic accuracy data. We identified a total of 296 studies and included a total of 16 after title and abstract screening, as well as full text eligibility screening. So here we can see some of the basic study demographics of the results. As you can see, some of the studies were conducted all across the country. There are 5 different technology types, which you can see at the bottom of the screen. They were tested in a variety of different locations, including on-site, in ambulances, in hospitals, and emergency departments, etc. And all of them, again, were portable and non-invasive. And so here I want to highlight a couple of things again. First, I organized all of these studies by purpose. So as you can see at the beginning, I talked about stroke detection. Later on, some of the technologies talk about differentiation of different types of stroke. And on the next slide, we'll see some technologies focus on detection of intracranial hematomas. The rightmost column also talks about time to results, which is quite important in thinking about feasibility of use of these technologies in a pre-hospital setting, as well as reducing time to treatment. Finally, at the top, you can see the 5 different metrics that we talked about regarding diagnostic accuracy. I wanted to highlight a couple of studies. So the first 2 studies use sonocite ultrasound technology in order to diagnose and detect stroke. And as you can see, the specificity, sensitivity, and area under the curve are quite high for both of these. The Cerebrotech Visor is a technology I mentioned a little bit earlier, but again, quite high diagnostic accuracy and severe stroke detection. On this slide, I just want to highlight the infrascanner, which is a near-infrared technology that again has quite high diagnostic accuracy, this time in intracranial hematoma detection. And in general, most of these technologies do have higher diagnostic accuracies than do the portable stroke triage scales that we mentioned earlier. Thereby, they could be implicated in improving stroke triage and improving accuracy of stroke triage in the future. So in conclusion, emerging portable technologies can help detect and stratify stroke, which could improve pre-hospital triage. There are many technologies still in development, some of which aren't even included here because of the lack of diagnostic accuracy results, but inter-technology comparisons are quite difficult because of variety in reported metrics. However, standardizing the evaluation of diagnostic accuracy metrics could further the optimization of clinical use of these technologies. In the future, we do hope to work on standardizing diagnostic accuracy metric reporting for these technologies, as well as better characterizing the impact of portable stroke technology in pre-hospital settings by using a model to implement these technologies at various points of care in both pre-hospital and hospital settings, and seeing how that affects the reduction of time to treatment for stroke patients and improves stroke outcomes in the future. Thank you. Any questions?
Thank you.
Hostess, how are we doing on time?
Very well. We are really doing well. Right on
Susmita,
time.
I want to ask Susmita a question. It's not so much about the science, but just how impressive this work is. How did you come to work with Chris Kellner, and how did you learn, what you needed to know to do something like this?
Well, Dr. Kellner is a great mentor. I just reached out to him because I saw that he was doing work in stroke and pre-hospital stroke tech, and I thought that was really interesting because I worked a little bit on technology in the past, and I thought that was an interesting application for stroke. And he's been a great mentor, and he's kind of showed me the ropes. And reading in his previous papers and his work with Cerebral Tech Visor has been a really helpful way to get more accustomed to what's happening in the field. And it's a hugely growing field, so just reading the new papers that come out have also been really helpful.
Thank you.
Yeah, it's just, it's nice that you bring that up, Dr. Betterson. I think, we're hearing research not only from our outstanding residents, but medical students, and then, students who've graduated from college who are looking to go to medical school. So it's really great to see the breadth of research from a variety of students at different levels in their career. Okay, so last but not least is Dr. Carrasquilla, one of our residents whose mentor was Dr. Germano, and his presentation title is Breaking Boundaries Through Doctors Reaching Minority Men Exploring Neuroscience, Dr. Men, a mentorship model for underrepresented minorities. Take it away, Alejandro.
Thank you so much. Can you guys hear me and see the slides?
Yes.
Okay, well, I want to tell you all about our experience with the Dr. Men program, which is a mentorship model for underrepresented minority males. The idea for Dr. Men really originated once the Association for American Medical Colleges came out with a statistic that between 1978 and 2014, the number of Black men applying to and matriculating for medical school in the US sustained a 5% decline. On top of that, there's a significant body of literature stating that the African American representation in surgery has been decreasing at a rate of 0.1% per year from 2005 to 2014, and the disparity is greatest at the highest levels of academic medicine, professorship, chairman, and dean. It's important to note that underrepresented minority patients have higher patient satisfaction scores, better compliance, and increased likelihood of participating in clinical research when a member of their physician provider team is also an underrepresented minority. Also, Black and Hispanic physicians tend to treat a higher portion of patients with their own race or ethnic background. Therefore, the aims of the study were to analyze the impact of a high school mentoring program on Black and Latinx students, as well as to evaluate the recent trends in Black and Latinx matriculation in medical school and neurosurgery residency. In order to do this, we tracked outcomes from Dr. Men participants in recent years, as well as collected their responses to the benefits of the program and how the program could be improved. We also collected data from the AAMC database about medical school applicant and matriculants, as well as the ACGME database for neurosurgical residents and the US Census Bureau for population data. A little bit about Dr. Men. Dr. Men stands for Doctors Reaching Minority Men Entering Neuroscience, and it was started in 2017 by Ian McNeil as part of a program portfolio in the Office for Diversity and Inclusion's Center for Excellence in Youth Education. Here you can see some pictures of the program from 2017 to 2019. And on the right, you see a timeline showing some of the outcomes from participants in the program. From 2017 to 2019, there were 4 participants in Dr. Men each year. And every year, one of the participants earned a full 4-year scholarship to college. In 2017 and 2018, one student each year also earned admission to a dual bachelor's and MD program. Now, 100% of Dr. Men participants thought the sessions were useful. 100% also enjoyed discussions surrounding the book, Black Man in a White Coat, which was done to the Sherman Scholars Program. 64% thought the sessions were excellent, and 36% thought these sessions were good. And in their free responses, they told us that they loved connecting with men of color in careers in medicine and neurosurgery. They told us they actually wanted more interaction with them and to discuss other topics, even outside of medicine. Now, when we collected data from the Census Bureau, from the AAMC, and from the ACGME, we saw that 12% of the US population was made up of Black individuals, 18% of the US population was made up of Hispanic individuals. But in medical school, only about 11% of the matriculants were of Hispanic ethnicity, and about 8% were of Black race. And nationally, in neurosurgery, only about 5% of neurosurgery residents were Black and 5% were Hispanic. So what do we conclude, and what are our future strategies? Well, we see that as our field becomes more specialized, it becomes less diverse. And this could lead to challenges in access to care. So we're trying to socially modernize the operating room. And by doing that, well, we're doing that in a number of ways. We believe that we need to expand this discussion to a larger stage. So the virtual format that we had to employ during COVID-19 has actually allowed for more participants. In 2021, this will include 7 Dr. Men participants, 12 Sherman scholars, but also we're going to be interacting with the World Federation of Neurosurgical Societies to elevate this discussion to a larger stage. So I just want to thank Dr. Germano for her tireless leadership, Dr. Batterson and Dr. Butts for their continued support. Of course, the program wouldn't be possible without Ian McNeil and Ernest Bartholomew. Dr. Salazar Jones is becoming involved in the program, just everyone who makes it possible.
Thank you, Alejandro.
Thank you.
Any questions for Alejandro?
I would like to give a big shout out to Alejandro, clearly, for presenting this work, and to Ian McNeil. For people that are not familiar with our program, Ian is a graduate of our program, currently doing a fellowship at UCSF. And he has been putting a lot of thought and effort into this. As Alejandro said, the program continues. We are, even if Ian is not with us, and the plan is to really make it into a much broader opportunity. Ian will be joining the faculty in Connecticut, and Ernest will move on to UCSF and to his next position. And with them and the WFNS, we're really trying to make this having an impact worldwide.
Okay.
Thank
well,
you.
That's the end of our presentations. I just want to thank all the speakers. We have a little bit of time for some discussion, but everybody did a great job. And I want to thank our judges who were able to score these presentations. And even the poster presentations went extremely well this morning. So thank you, everybody, for your hard work today. Really proud to see all this great research.
Costas, as far as finishing up, we're going to give the Post Award, and are you going to be announcing the winner, because this has been collated in real time?
Yeah.
We need a couple of minutes to calculate that.
I think we're almost ready. Let me just confirm this.
I'll take a chance just to highlight some of the non-medical student and non-resident presenters we had. We had a few college students and master's students and master's degree presenters. So maybe if the mentors of those individuals could just comment on who they are and how they got here today. Neha?
Sure, thank you so much. This has been such an inspiring morning. So Diksha Chadha, who is our NEMA data analyst, was born in Hyderabad, and she moved to the US in 2000, and she went to undergrad, University of Iowa, MPH at Columbia, and she's joined us as the NEMA data analyst since 2019. Her goal and aspirations are to join the CDC, and we're hoping her experience with us is going to propel her career in the right direction. And she's helping us develop NEMA 2.0 with big data analytics. Thank you.
Thanks a lot, Neha. And then, Kostas, do you want to comment on Carolyn?
Yeah, definitely. You know, Carolyn has been a pleasure to work with. She's been in our lab now 2 years. She's a graduate of Penn State. She's actually done a number of projects in the department. She worked with Dr. Betterson Leslie a summer or two ago. But, you know, she's done such a nice job working with the model she presented today. She did most of that work, and she created ways to move it forward. So, you know, these are the types of things that really excite me with our students and how they think about things and solve problems. But she's going on to medical school in New England next year. So really proud of her and what she's done.
And
Thanks,
then
Dr. Hodgepanias.
And then Nikki Mohammadi is a graduate of Barnard from 2 years ago. She's been with us for 2 years and has worked on a lot of projects and has been a B Foundation Fellow for us, meaning she was working on a project funded by the B Foundation looking at cost effectiveness, the cost of an aneurysm rupture. And she's also been a clinical coordinator working with the research team. And then really has taken ownership over this qualitative assurance, qualitative research approach to understanding the patient perspective and has done an excellent job, as you can see today. She's going on to a master's program and eventually to medical school. Thank you, Nikki.
Awesome. Well, we have the winners now. Dr. Betterson, do you want to announce the Dr. Post Award first, or should we do the research?
No, you go ahead for here, and then we'll finish with Post.
Okay. Alyssa, can you put up the slide for us? So again, we've heard some really good presentations today. We tried to get all the subspecialties covered, so hopefully we achieved that. Let's see here. She needs a few seconds here, but maybe I can just announce it. Is that okay? Yeah. Let's see.
Costas, I have it.
Okay. Can you share it?
Yeah.
Thank you. We need a drum roll here. And again, thanks to Linda Liao. I mean, she's stuck with us this morning and really appreciate all your help today. So it was really fantastic. Okay, so our first place winner for our research day today goes to Alex Schuper. I'm sorry, no, not Alex Schuper, Jeffrey Zimmering. I'm mixing up awards here. Sorry about that. Jeffrey Zimmering got the first place for the Research Day Award today. He discussed some of his work he's doing on chronic pain in the Zacariu lab, which is the Department of Neuroscience here in Mount Sinai. So Jeff Zimmering, congratulations. I know you're working hard and really looking forward to see your high impact paper come out of the work you're doing.
Thank you.
And we also have a runner-up.
And then our runner-up is Dr. Ray Fang. I'm sorry, Carolyn Rosea. Yeah, I know we have all these awards. Carolyn Rosea is our runner-up, who's actually my student in my lab, who you heard about, and she presented the work on the magnetic hyperthermia therapy. So congratulations, Caroline. Your hard work is really appreciated.
Thank you so much. I really appreciate it.
Congratulations to both. Really, really superb. And I do want to make a couple of comments about Research Day, and also to thank Sukaina Davdani, who many of you may not know as well as you should, but she has really put herself out and devoted herself to this process, making it outstanding. So thank you, Suki. Much appreciated.
Thank you.
There are a couple of thoughts I have this year, the 25th year of Research Day, and probably we're just going full circle. In fact, I'm going to stop sharing just for a minute. We're probably going full circle somehow, in that in the first Research Day in 1996, really, we asked everyone in the department who was doing research to present. As Research Day grew and the department has grown enormously, we thought that was not possible. Back in 2014, it was called Research Week because we had reached a large size, and we wanted to include everyone. Over the past 5 years, we've developed a selection process that Kostas and Sukaina have done nicely this year. But I think I want to go back full circle to where we were. Research it's the cornerstone of what we do. And so in next year, in the coming years, we will have categories. It may not be one day that we can do it all, but it's going to be an expectation that if you're a resident in this program, you'll present your research that year. And we can still grade it and score it, and we're interested in the quality of the work and to recognize the great quality when it is outstanding. But everyone will be expected, and we will also invite any of the students and medical students who are doing work in the department. And if you're an attending that is doing research here, we will also expect this to be done. So I think that's a full circle that we'll probably be coming back to next year. So let's just go back then and get to the post award. Cal was the one who initiated this, and he always wanted to differentiate between research that is being done and research that leads to a publication, and particularly among residents. And that's why he calls it the Neurosurgery Resident Publication Award. His family established an endowment to support this award, and it is judged by the department's full professors. Here were the submissions this year. Kurt Yeager and team, time from acquisition to endovascular team notification, a new target for enhancing acute stroke workflow. Alex Schuper, Kostas Hadjipanias, Ray Young, and a whole host of other people from our centers and others, looking at 5-ALA in a prospective multi-center study. Abi, working on pituitary germinomas. And Ray, working with Dr. Germano and others on women in neurosurgery. So these were the submissions, and we're happy to announce that Alex Schuper, for his work on 5-ALA, is this year's winner of the Post Research Publication Award. Congratulations to you, Alex. And this year's runner-up is Ray Feng. I always announce the runner-up, but it was very close. But this outstanding work was recognized by the professors. So I think with that, we are done with Research Day today. I want to thank you all. I'm deeply impressed by the quality of work, particularly of the students, but obviously without the serious mentorship of the attendings, that doesn't come to fruition. And also that, Linda, you joined us and stuck with us throughout the whole 30 presentations, and your comments, your talk, your presence are really, really greatly appreciated. So thank you.
Well, thank you. I just want to say how impressed I was with all the presentations and the format and how inclusive you were of, the undergrads and the med students and really, raising that culture of research. I mean, very impressive. And congratulations to the award winners. Very well deserved. Thank you for inviting me. I learned a lot.